previous batches, of course, I haven't discussed it, right? But the thing is, this is a new topic as well as this is a very important topic. So the thing is, guys, so these days, of course, it's most of the people are talking about these things. The more than just the COVID-19 itself, the MIS-C is very important because the COVID-19 is a huge area, right? If we are going to discuss about COVID-19, it takes like, we need to do like several hours. So MIS-C is something very interesting area, and the most like very interesting area, and it is a short topic. So thing is, more importantly, why we are mainly worrying about the MIS-C, sometimes you might not be able to diagnose, and the delayed the diagnose can be like it can cause more can kill the child, right? So the basic. So thing is, you need to identify early. At the same time, there are other DDs also there. So the thing is, you need to identify those conditions also. Sometimes the overdiagnosis of MIS-C also very common. So when we are discussing, after discussing MIS-C, don't think all the things are MIS-C, right? Keep that in your mind as well. So thing is, guys, so here we are going to discuss the MIS-C, then we'll move to the questions, then you will understand everything so clearly and nicely. So the key important point is, guys, so you must have heard about MIS-C previously, must have joined some lectures maybe. But the more importantly, the thing is, guys, so there are undergraduate related stuff are there, right? So which we are focusing, right, which we might ask in your exams. You need to focus on those points, right? So there are important points are there which you need to know. So this lecture is mainly for the undergraduate students, for the medical students, right? So keep that in your mind. So the thing is, here I'm not going to discuss the doses and how do you need to titrate, how do you need to reduce it. So those things, of course, I'm not discussing because those things are not important for your like the exam purpose of point of view. It's not so important. So I will highlight you the most important points. So then you will be able to understand everything so nicely, and you will be able to answer whatever the question, right, about MIS-C, right? So MIS-C as well as the other related differential diagnosis. So the thing is, guys, so yesterday I gave this MIS-C lecture note as well as the MCQ paper also. So thing is, guys, so if we quickly move to if we start the lecture, so here, guys, so keep this in your mind. So thing is, guys, so MIS-C is very important, so you need to listen very carefully and concentrate and write down the key important points. I might tell you more which are not there in the note, so you need to write down those points as well. So the thing is, guys, regarding MIS-C, so we are telling MIS-C is multi-inflammatory syndrome in children, right? So the multi-inflammatory syndrome in children, so there are so many terms are there for the MIS-C, right? So in the US, of course, that's the US term, right? So the UK, of course, they are using PIMSPC, right? So that's something different. Pediatric inflammatory multi-syndrome, temporary associated with COVID-19. So it's totally different. But the thing is, even the US have US people used to call this as multi-inflammatory systemic syndrome in children. So even the WHO also currently using this term. So here also in Sri Lanka also we are using this one. So you need to be familiarized with this term. So this is about the MIS-C or the multi-inflammatory syndrome in children following COVID-19. So here during the lecture, guys, so we are going to discuss about these basic stuff regarding the MIS-C and the epidemiology and the risk factors, and you need to know the pathophysiology. So if the problem is, guys, so MIS-C is, I have seen even most of the doctors also find difficulty to remember the things, right? And they are able to work out, they don't know how to treat the patients rationally because they are not well aware about the pathophysiology. Even it is not properly understood at this moment. So the thing is, we know, we can assume what is the pathophysiology. So then you will be able to work out and you will be able to treat the patients so properly. So then we are going to discuss about the clinical features. Again, very important, guys. So the thing is, then we are discussing about the DDs. So the thing is, it's sometimes there are these features can overlap with the other medical conditions as well. So you need to you need to know what are the differential diagnoses, and as well as how are you going to narrow your diagnoses, and how are you going to identify the MIS-C, exact MIS-C. So the investigations we are going to discuss, and the diagnosis criteria of the MIS-C we are going to discuss. Then finally, the management. So if you know if you can remember, if you can recall the facts under these 8 points, then of course you know everything about MIS-C. So the thing is, guys, here, MIS-C, of course, guys. So initially the thing, it was diagnosed in the UK. First child was noticed in the UK on April 2020, right? So then, of course, guys, then they noticed few cases in the US, the Spain, right? Italy, several cases developed. So initial case noticed in the UK in 2020, again in 2020 April. So 2020 May, I again did the YouTube program to aware the community regarding this MIS-C. Actually, those days they were doubt regarding whether it is the Kawasaki is getting. So I did. It's there in the YouTube. You also can listen to that as well. So the thing is, guys, first the case was noticed in the UK in the 2020 April, and the Sri Lanka we noticed the first case in 2021 January, right? So it's nowadays we have seen enough cases. So there are in the LRH also they have managed more than 50 cases, right? So the thing is, guys, now it's rising with time. So the thing is, guys, initially the thing is, this is actually, so just like it's almost like a Kawasaki. So the Kawasaki also usually develops following an infection. So there will be an immunological response, and they will develop some inflammatory features. So here also it's almost same, where the primary etiology we know, the etiology is this happens following COVID-19 infection. So the COVID-19 infection, super antigen. So then they will be an immune mediated response, hyper response. Then they will develop these Kawasaki mimicking features. So that's what we call it as MIS-C. So the thing is, guys, so as I mentioned, so the thing is they will initially develop COVID-19. They will have some sort of super antigen. Then there will be an immune response. Then they will have almost Kawasaki-like features, like atypical Kawasaki features, majority, and they might have some more. So if it is the etiology is COVID-19, we call it as MIS-C. So thing is, guys, so here disease, the important thing is, guys, so initially you notice only in children, but the thing is, guys, it's not only in children, it's sometimes you will notice in young adults as well. So now, even yesterday, at the moment also, there is one patient in the Sri Javardhanpura medical ward, right? The child is 16 years. Again, treating so they got opinions from us also. Their child is currently treating as MIS-C, right? So thing is, child is having MIS-C. So it's not the pediatric age group is 0 to 14 years. So even sometimes you might notice young adults in the young adults as well. So thing is, guys, those days even we used to say MIS-C, you can apply this as a MIS-A also, right? So the multi-inflammatory syndrome in adults, right? In like you can ask even in your medicine paper also, it's possible. And MIS-N, multi-inflammatory syndrome in neonates, right? So thing is, guys, so that is very important. So you need to know in and out regarding MIS-C, right? So the thing is, guys, here, so since the COVID-19 in children, so the thing is, guys, so the COVID-19, you know, it is it common in children? COVID-19 itself, is it common in children? No, compared to adults, it is less common. Why is that? What's the reason? Why do you see more COVID-19 cases in adults and less in pediatrics? What's the reason? So the thing is, guys, I think you must have heard. So the thing is, there is something called AC inhibitors. So the thing is, guys, so cells used to express these AC inhibitors. So usually the COVID-19 viruses get bind to these AC inhibitors receptors, right? So that's how before they enter to the cells. So it's necessary to have AC inhibitor receptors, then they can have, they can enter the cells. But in children, of course, the expression of these AC inhibitor receptors are less, right? So that's why it's most of the time they will be asymptomatic even they get the virus. So even they get the disease also, they will be mildly symptomatic. So the reality is, guys, only the 1% of the children will come to the hospital. So they will admit to the hospital. So 99% will be in the community or at home. So they will not come to the hospital in children. So because they must have developed COVID-19, they must have developed symptoms or not. But anyway, even if they develop symptoms, it will be mild. So they will not come to the hospital. So the 1% you will notice in the hospital setup. So the thing is, guys, it's like, so thing is, there are so many COVID-19 cases are there. Reality is, COVID-19 cases are there. So they where you like the thing is, which they are not well aware. So even the parents are, yeah, අපේ පුතාට නම් COVID දෙන්න බෑ. මේක නිකන් එම්බිරිස්සාවන පීනසයන්. So they will tell like that. So thing is, they will not come to the hospital. But the thing is, guys, so here, but even how much their immunity is good, how much they are asymptomatic. But the thing is, we can't predict about the developing the MIS-C. So some children can develop the MIS-C, right, due to the genetic influences as well as the releasing of the other cytokines, the release immune mediated responses. So some children can develop this MIS-C. So the thing is, guys, the key important point is, guys, so the most of the MIS-C children may not have past history of COVID-19, right? So they might say, අපේ පුතාට තිබ්බේ නෑනේ. එහෙම කියයි. Right? So they might say, අපේ පුතාට නම් COVID හැදුන්නේ නෑ. Right? So the reality is, because they are asymptomatic, but the virus has been, they got the virus, but they were asymptomatic. So the thing is, guys, so this is a post-COVID thing. So the thing is, most of the time this develops around 4 weeks time or after 1 month period, around 1 month. So usually 2 to 6 weeks time. So thing is, guys, so by that time, most of the time the viral load has been reduced. So the thing is, the rapid antigen will be almost always negative in these children, right? So even we haven't seen even a single case with an MIS-C who got a positive rapid antigen test in Sri Lanka. And also the majority will have a negative PCR as well. So that's the thing. So very difficult, sometimes very difficult to diagnose, and the parents also might not accept. So අපේ බබාට COVID හැදුනෙත් නෑ, PCR උත් negative, rapid antigen එකත් negative. ඔයා කොහොමද ડોක්ටර් කියන්නේ මේ COVID එක හින්දා කියලා? Right? So thing is, guys, so sometimes they can have, so thing is, the serology will be majority serology, or the antibodies will be positive. Majority, right? So we'll come to that. So the thing is, keep those things in your mind. So the important point is, guys, what the MIS-C is rare things. So the thing is, please don't overdiagnose. The common things are common, right? So there are mimicking conditions are there where, for example, don't think that MIS-C is commoner than the dengue. So sometimes it might mimic the dengue also. So dengue is very much common compared to MIS-C. So the MIS-C incidence is 1 in 5,000, right? So can you assume? So they were like even in LRH also, there were more than 50 patients are there. And can you imagine how many patients should be in the community? Minimum children. How many people? So there should be minimum of 250,000. So that is ලක්ෂ දෙකමාරක් ළමයි ඉන්නවා හැදිලා තියෙන්න ඕනේ, right? So thing is, that is underdiagnosed. So the problem is, guys, the more it is life threatening, and some children can die. So it affects the heart. So it can cause they can go into a shock. So they die. So you need to identify early. You need to start treatment early. Otherwise, children can die. The mortality is around 2%. So thing is, guys, even nowadays it's very rising. So thing is, in Sri Lanka, in LRH, I told you there were 50 cases were there. So actually, one child died, right, with a late presentation. So the reality, so the thing is that is around 2%, right? Mortality. So it is life-threatening conditions. You need to identify early and start the treatment as early as possible. So the age of onset is, guys, so it's usually around 0 to 21 years. The peak age is around 10 years. Right? අවුරුදු 0.20යි අතර වැඩි බාහිතරයක් ඉන්න අවුරුදු 10 අතර. So 8 to 12 years the peak incidence. So the key important point is what? So in Kawasaki, so I told you it's almost mimicking the Kawasaki. So Kawasaki disease usually you will notice in what age group commonly? So commonly you will notice in age you will notice in preschool children. So between the 6 months to 4 years. But here it is more commonly noticed in the schooling age or the adolescent age group, right? More commonly noticed in adolescent age group, but can notice in either 0 to 21 years. So even in Sri Lanka also we have got one case, the child was 2 months. Then there was a 17-year-old child also was there. But the majority were around 10 years. So there is a male predominance is there. So 70% of the time the thing is most we have noticed among males. And the thing is, guys, so that is very important. So it's like iceberg, right? So the thing is, there are so many cases are there, but the thing is, so many COVID cases are there. So that's why you will know, you see this number of missy cases. So thing is, guys, most of the time, so it the number of COVID, number of missy cases are directly proportional to the number of COVID-19 cases. I told you it is incidence is 1 in 5,000 in children. So COVID gana වැඩි වෙද්දී missy gana වැඩි වෙන්න පුළුවන්. So the thing is, COVID usually occurs like peaks. Peaks එන්නේ. So the thing is, guys, missy also incidence also then gradually starts with like that. ඊට පස්සේ ඔන්න peak එක එන්නේ. So keep that in your mind. So the missy also there. So the thing is, guys, so is it common in Sri Lanka? So is it comparatively common in Sri Lanka? Missy is it comparatively common in Sri Lanka? Comparative. Yes, guys. Yes. Why? So thing is, guys, I don't know whether you have heard this. ලංකාවෙන්ම හොඳටම කරේ අපි කියලා අන්තිමට අනිත් පැත්තට හොඳටම කළේ වුණානේ. What? නේද? Can you remember? So what happened actually? So thing is, guys, so here it was not about the number of cases. It was about the COVID-19 cases per million population. Million එකකට කීයක් COVID ළමයි හිටියද COVID patients ලා හිටියද කියන එකයි ඒක අනුව තමයි අපි අන්තිමට මේ මෑතකදී first උනේ අනිත් පැත්තේ. Right? So the thing is, guys, so the New Zealand it is 0.6%. Right? It's very low per million population. India it is 68. Again, that's not that much. It's not that much high. The UK it is 95, but in Sri Lanka it is 113 cases per million population. So that is very high. So you will notice the huge amount of number of COVID-19 cases, the missy cases in future. So that's why you need to know how to manage those conditions. Manage missy. So the thing is, guys, there are few risk factors are there. One of the important thing is, guys, so we have noticed there is an incidence also high and the severity also become higher in children who are obese. So in dengue also it's the same. If they are obese, so they are whatever their mortality and the morbidity will be high, right? So the obese itself, for whatever the condition, right? So it is a risk factor. So even in dengue. So there again the bronchial asthma also an risk factor as well. So the thing is, guys, what happens exactly? What happens exactly in this missy? So the thing is, guys, so listen carefully. So don't get so confused. It's not so difficult. So the thing is, guys, the children will get an COVID-19 virus. And they will have super antigens. So the COVID-19 will be there and they will have super antigens. So So the thing is, guys, these things will get engulfed by the macrophages. So the macrophages are unable to macrophages, and macrophages will get activated. So the macrophages will get activated following an COVID infection. So the thing is, guys, macrophages, they try to destroy this virus, but they are unable to destroy it. Destroy කරගන්න බෑ. So what happens is, then they will take some help from the T helper cells. T helper cells, so you must have heard, so T helper cells, right? So they will get some help from the, right? So due to some genetic influences from the child itself, some children might not develop the proper immune response. So they will develop some sort of very abnormal immune response. So T helper cells used to release adequate amount of cytokines, and the adequate they will help to convert the B cells into plasma cells. Where the thing is, they will then, of course, they will produce proper antibodies, and they should be able to destroy. But what happens is, these T helper cells, right, due to these genetic influences, once they get exposed to the superantigen of this COVID, they will not be able to regulate the proper immunity. So what happens is, there will be two important things will happen. So what happens is, one thing is, guys, but they will release excessive amount of cytokines. What do you call that? You call it as cytokine, excessive amount of cytokines. It is excessive amounts of cytokines. We call it as what? Cytokine storm. So that is a huge amount, right? You must have segment types interferon, interleukin 1, interleukin 6. So many these cytokines are there. They will release huge amount of cytokines. Then the other hand, what happens is, guys, then they will help, T helper cells will help B cells to convert into plasma cells. So they will produce some antibodies. So they will produce some normal antibodies as well as, right? May produce some normal antibodies as well as may produce some abnormal antibodies. So abnormal antibodies and the normal antibodies. Right, so they will produce some abnormal antibodies as well as normal antibodies. So abnormal antibodies, sometimes we call it as non-neutralizing antibodies. So these antibodies will bind to the virus, but it will not destroy. So it doesn't help to destroy the virus. So these abnormal antibodies, so they will cause other problems. So because due to this cytokine effect and because of these antibody abnormal antibodies, so the thing is, guys, they will have hyper-inflammatory response, excessive amount of inflammation, hyper-inflammatory response. So the thing is, whole inflammation. So the thing is, guys, the inflammation can be there in where? So it can occur in the organs. Mainly involves the skin and mucocutaneous membrane, the GI tract, and the cardiovascular system. Specifically, can you all repeat? The mucocutaneous system, then the GI tract, gastrointestinal system, as well as cardiovascular system. So it will cause a lot of inflammation in the organs, specifically mainly in those three organs. Can involve any organ, can involve any organ, kidneys, brain, anywhere, but commonly involve the GI tract, skin, GI tract, and the heart. Then, of course, guys, it will cause inflammation of the vessels. So vessels, it can be small vessels or medium-sized vessels. So the thing is, guys, so they will have damage to these, mainly the medial size vessels. So the thing is, it will damage to the coronary, inflammation of the coronary artery can be there. And also there will be an inflammation of the other vessels, so they can have vasculitis. And they will have vasodilatation. So the high vasodilatation will be there. So because of there is hyperinflammation, of course, you will notice an excessive amounts of high levels of inflammatory mark, all the inflammatory markers. Inflammatory marker sky high venom. Is it easy? So can you all remember? So the COVID-19 virus, it's a super antigen. So macrophages get activated but unable to destroy. So they get the help from the T cells. But with some genetic influences from the child, some children are unable to destroy the virus properly or produce the proper antibodies properly. So they will, rather than producing the proper antibodies, these T cells will release excessive amount of cytokines, that is called cytokine storm, as well as it will help to convert the B cells into plasma cells. So they will produce some abnormal antibodies, right? Or the non-neutralizing antibodies on top of normal antibodies. So what happens is, then of course, most of the time, it will cause inflammation of organs, mainly involve the skin and mucous membrane, the heart and the GI tract, and also the inflammation of the vessels. So it will cause the vasodilatation and hypertension. It will cause the coronary artery inflammation, as well as the other vessels inflammation. So at the same time, because of this hyperinflammatory response, you will notice high levels of these inflammatory markers. So I clear? So that is what we will notice in the these thing. This MIS-C, this is the primary underlying mechanism. So if you identify, you will, if you can remember this, so inflammation of the organs, inflammation of the vessels due to so much of cytokines and the abnormal antibody. So then of course you will be able to work out anything. So thing is, guys, so the clinical features. So thing is, guys, so here keep this in your mind. Clinical features, usually the onset will be between 2 weeks to 6 weeks. So around 1 month's time, Marcia capsules. By that time, what will happen? So most of the time, virus has got settled. Ogulanta COVID, most of y'all have experienced COVID, no? So thing is, Nirodayane kochchara kalayak unada. So they must have asked you to say 2 weeks. No. So thing is, guys, so the viral load will be significantly get reduced. So that's why by the time of getting the MIS-C, so the rapid antigen test will be definitely negative, almost always. So the PCR will be, sometimes it can be positive, even that also the infectivity is very low. So thing is, usually the MIS-C infectivity is like, it's not so highly, it's not infective most of the time, right? So let's keep that in your mind. MIS-C lamika dakkama ammo COVID kiyala baya wenna lokuwata onne, most of the time it is not that much infective. So the thing is, guys, children with the COVID-19, most of, as I mentioned, most of the time asymptomatic or mildly symptomatic and do not have a history of COVID-19 in the past. So very difficult to sometimes diagnose the condition, right? So the thing is, since it is a post-COVID syndrome, the COVID after 2 to 6 weeks time. So the thing is, guys, so most of them will not have the classic symptoms like respiratory symptoms, sore throat, rhinorrhea, right? Absence of smell. So those things, of course, you might not notice. If you ask from the patient, they will say, no, I don't have anything, right? So those signs are, of course, those are uncommon, right? So the thing is, guys, you need to know the clinical features. So I told you, it's a Kawasaki mimicking condition, right? So just learn things so nicely. So one of the important thing is, guys, the fever. Fever natural MIS-C, and this is a hyper-inflammatory response. Whatever the signal with an immune mediator, high inflammation, so they just like the Kawasaki, so they will have a high-grade fever. So that will be there. So you definitely fever will be lasting more than 3 days, and it is very high grade, or the remnant fever. So remnant is what? They will be having high grade fever, but usually they will not come to the baseline. So they have a baseline, right? It's a very high grade fever and not respond to paracetamol or antibiotics. So the thing is, guys, in a conditions like sepsis, so they will respond to antibiotic drastically. And the most of the conditions, they will respond to paracetamol. So these immunological conditions usually will not respond to paracetamol. So it's like the Kawasaki. Kawasaki also, the PV is same, right? So here also, it's same high grade, remnant, and not responding to paracetamol or immunoglobulin. So thing is, guys, so they will have myalgia. So that's of course not so common in Kawasaki. So they will have myalgia. So the myalgia is more commonly seen in what condition? ඔය වගේම උණත් එක්ක myalgia එන්නේ මොකද්ද? So sometimes they might come අම්මෝ ඇඟපතර දෙනවා, මස් පිඩුරේ දෙනවා. So it will be tender. If you compress the muscles, sometimes can be tender. It's not a very common feature, but it can be there. So the thing is, guys, it's sometimes you might notice in leptospirosis. No. So that's why you need to be very careful when you're differentiating, because, right? So keep that in your mind. So the Kawasaki, so they will have a Kawasaki-like features. So keep this in your mind. Kawasaki will, if you can remember, because recently, like last week, I discussed in and out regarding Kawasaki 2 times, right? In both papers, which I discussed in the free online session. So the thing is, guys, hope you all can remember. If you try to recall from head to toe, what are the features? So in Kawasaki also, they will have conjunctivitis. So here also they will have conjunctivitis. It is very common, very common, very common. Even in this Missy, even Missy also, the conjunctivitis is very common. So you will notice in more than 70% of the children. So more than 70% of children will have positive conjunctivitis, right? So the thing is, guys, so it is bilateral and non-suppurative, right? So the thing is, because it's a systemic immune mediated, can't have pus, no. So since it's not a direct infective one, so it is systemic one, so it will be bilateral. So then, of course, guys, so you can remember, so the thing is, guys, erythematous pharynx, cracked erythematous lids, and as well as they will have strawberry tongue, strawberry tongue, strawberry tongue. So just like the Kawasaki, they will also have a strawberry tongue. So keep that in your mind. So very difficult to sometimes differentiate. So right. So it's also not uncommon, those features, but not common as conjunctivitis. So you will notice around 50% of the patients. Then you will notice a rash. So most of the time, again, you will notice some sort of a rash. So thing is, guys, the rash can be either what? So they can have what? Just like a immune mediator. So they can have a maculopapular rash. And also sometimes the thing is, I told you, it causes vasculitis. So then what kind of a rash do they develop? Following vasculitis, I have taught you all. So they will develop a purpuric rash. So the purpuric rash is very common. So they can have associated low platelets also. They can have petechiae. So and the entire body can get erythematous, erythroderma also possible. So those are the common ones. So the thing is, they can develop whatever the rash. So then, of course, cervical lymph nodes are also can be positive. It's usually bilateral. So the thing is, guys, so the Kawasaki, of course, 80% of the time you will notice cervical lymph nodes. But here, of course, you will notice around 20%. So the important point is cervical lymph nodes are not so prominent compared to Kawasaki. So in a case scenario, we might not highlight that much regarding cervical lymph nodes, but we will highlight about conjunctivitis very much because it is so common in Missy, right? So then, of course, here also, just like the Kawasaki, they can have inflammation of the hands and feet, right? So that's also possible. The desquamatization also, yes, possible. So then, of course, we will move to the next important thing. So I told you, they, in addition to the involvement of the mucocutaneous area, so they love to attack the GI tract. So keep this in your mind. The GI symptoms are so common. More than 90% of the cases will have GI symptoms. Even in Sri Lanka, it's more than 80% of the children had. So it is very common, guys. So you need to know. So most of them will have abdominal symptoms. So they can have either vomiting or diarrhea. So diarrhea is very common. So don't get confused. And the other thing is, guys, but they will have abdominal pain. So sometimes the thing is, guys, I told you there will be an inflammation of the GI tract. So when there is an inflammation, they will have colitis and the inflammation of the mesenteric vessels. So they will have vomiting. Sometimes they might have diarrhea. Sometimes they might pass a little bit blood with the stools. It's possible, right? So they can have abdominal pain. So it can be generalized, or it can inflame the liver. So they can have hepatomegaly and the tender right iliac fossa, or they can have right hypochondrial pain, or they can have right iliac fossa pain. So keep that in your mind. I have seen enough cases, right? Even recently also we had a case at Jayawardhanpura. So from the ETU, they have suspected appendicitis. They have transferred to surgical unit. Then in the surgical unit also, what the PO was there, CRP high, child is vomiting, right hypochondria, right iliac fossa pain, scan, ultrasound scan, no evidence of these inflamed appendix. But the thing is, appendicitis usually diagnosed clinically. So what did they do? So they opened the tummy, right? So there's no inflamed appendix. So then they closed and they did the referral to us. So then we were able to diagnose this is nothing else. This is Miss C, right? So the thing is, guys, there were several cases there children who had an appendicectomy, right? After undergone an appendicectomy, but the real case was the Miss C. So the thing is, keep that in your mind. That's very important, right? So the thing is, some children might be undergone a laparotomy even, right? So sometimes they might complain generalized abdominal pain. So be careful. So don't just look at the other signs as well, because the surgical team, they are not well aware. So the child had obvious conjunctivitis, but they were not well aware at that time, right? So keep those things in your mind. So don't miss see, that is very important. So then, of course, guys, so I told you, what is the next important organ? So they love to attack the heart cardiac system. So thing is, guys, so what are the things which you notice? What are the components in the heart? So the thing is, guys, inside the heart, there are 3 layers are there. So the first one is endocardium. Then the next one is the myocardium. Then the most outer part is the pericardium. So the thing is, guys, it's a hyper-responsive inflammatory condition. So thing is, it will inflame everywhere. So it allows to attack to the heart. So it will inflame the endocardium, it will inflame the myocardium, and it will inflame the pericardium. So on top of that, in addition to that, it will inflame the coronary arteries as well. It will inflame the coronary arteries as well. So keep that in your mind. So it will inflame everything, the endocardium, myocardium, and the pericardium. So when it inflames the endocardium, what can they have? So they can have mitral, so they can have valvular dysfunction, right? So that's common. So commonly it will involve the mitral valve. So the thing is, don't get surprised after listening to a murmur, right? They can have a murmur, mainly the mitral regurgitation murmur, which is an pan-systolic murmur over the apex. It's possible. Then it can cause myocarditis and the cardiomyopathy. So they will have inflammation of the heart. So the heart will unable to pump. So heart can get easily, but can get right. So they can have heart can get weak. So they can have left ventricular dysfunction. So they can have pericarditis. That's also possible. So inflammation of the myocardium can lead to sometimes arrhythmias even. So the thing is, guys, I told you it can inflame the blood vessels as well. The most of the important thing is, guys, it will inflame the coronary arteries also. That's very scary. But the key important point is, guys, so the coronary artery inflammation, here it will cause more inflammation rather than the aneurysm. So the thing is, they are more prone to develop thrombosis, of course. But the developing the aneurysms are less common compared to the Kawasaki. Kawasaki antibodies weaken the blood vessels. But here it doesn't weaken the blood vessels that much. It also can cause coronary artery aneurysms. But more commonly, it will cause the inflammation and the thrombosis. Good. So what will happen, guys? So keep that in your mind. So the thing is, guys, in addition to that, it can cause systemic vasodilatation. So it can involve all the blood vessels. So it can cause these cytokines can so many cytokines. These cytokines cause systemic vasodilatation. What will you classically notice? Hypotension, hypotension, hypotension. Even in the sometimes the cardiac, even in the absence of the cardiac dysfunction. So the thing is, cardiac functions are normal sometimes, but they will have a hypotension because due to this vasodilatory mechanism. So if you know these mechanisms properly, pathophysiology, you can work out. Good. So the key, I told you, what are the three most important organs? So the thing is the mucocutaneous region, the skin and the mucous membrane, then the GI tract and the cardiovascular system. So that's more than enough. Are you clear up to now? Good. So the thing is, guys, so the thing is the respiratory involvement. I told you it's a post-COVID thing. So most of the time, so these signs are minimum, right? So these are their symptoms and signs are minimum. Cough is an uncommon. Now the sore throat is very uncommon. So sometimes they can have few features following, but pulmonary edema. So the thing is, guys, so when after a myocarditis, heart is unable to pump, so they will develop. Sometimes they can develop these pulmonary edema. So the accumulation of the fluid in the lungs, right? So the pulmonary congestion or the pulmonary edema. So other than that, the COVID-19 per se, COVID pneumonia is uncommon and the cough is uncommon. So the thing is, guys, so following these cardiac manifestations, so most of the time when there's an inflammation, they can complain about chest pain or dizziness or palpitations. Those are common symptoms. So the thing is, guys, the renal manifestations are again uncommon. So the thing is, that's right, like conditions like leptospirosis, it is very common. But here it is uncommon, can involve the kidneys, but it is uncommon. Then again, the neurological manifestations, of course, they can develop these antibodies and the inflammatory mediators can affect the brain. They can develop the meningoencephalitis. It can cause strokes following it's a thrombogenic condition, so they can develop strokes. The seizures, right? Seizures due to many causes, maybe due to stroke itself, maybe due to hyponatremia, also common. That's again yes. So the thing is right, they can have coma, but the thing is, guys, the CNS manifestations are also uncommon. So the thing is, guys, can you see in the most of the slides I have showed a red eye? So it's not the typical red eye. So usual sclera is the one which get red, but the important point which I wanted you all to get highlight is, so the majority of the children will have conjunctivitis. In your questions, most of the time they will mention the conjunctivitis and the abdominal pain. So keep that in your mind. So these are the clinical features, guys. So they can have red eyes, conjunctivitis, enlarged lymph nodes, the rash, right, strawberry tongue, then the swollen hands and feet, and the abdominal symptoms, diarrhea and vomiting, and the cardiovascular manifestation, right? So keep that in your mind. So before moving to that, so can you, again, if I quickly brief you. So I told you MIS-C is an uncommon, these days it's rising. Again, the thing is, don't, MIS-C is not a so common condition, so don't overdiagnose. But the thing is, if it is a MIS-C, you need to identify early, and treatment is early treatment is necessary. So where you can reduce the mortality. Then, of course, the age of onset is usually you will notice around 10 years. You can see between 0 to 20 years. So commonly you notice around 10 years. So the thing is, guys, the pathophysiology I told you, the following and virus, mainly COVID-19 virus. So the thing is, macrophages will get activated. They will ask the help from the T helper cells. But due to these genetic influences, some children are unable to produce proper antibodies and immune response. So they will produce abnormal antibodies and the excessive secretions of the cytokines. So these excessive amounts of cytokines and as well as these antibodies will damage the organs. They are mainly the heart, GI tract, and the skin and mucous membrane. In addition to that, it will damage, it will inflame the vessels, so they will have vasodilatation and the inflammation of the coronary arteries, and which you will notice a markedly high inflammatory markers. So here I told you, usually the onset is between it's a post-COVID, around 1 month's time, 2 weeks to 6 weeks. By that time, most of the time, the PCR and the rapid antigen negative, most of the time negative, and the PCR also can be negative in majority. And the thing is, guys, since the children are asymptomatic, most of them will not complain and he past history of COVID-19. So that's the difficulty in diagnosing these cases. So here the classic features are fever, the high-grade ruminant fever, which does not respond to paracetamol or antibiotics. They will have myalgia. Then they will have all the features of Kawasaki. The conjunctivitis is the most important feature out of those Kawasaki-like features. Then they can have GI manifestations, mainly the diarrhea and the abdominal pain. So those things are very common. Sometimes can mimic the dengue, sometimes can mimic the lepto, sometimes can mimic appendicitis. Sometimes they can have cardiovascular manifestations. So the endocardium, myocardium, and pericardium, anything can get involved. So commonly they will go into myocarditis and cardiac failure. So the left ventricular dysfunction is very common. So they can have arrhythmia. So they will commonly complain about chest pain and the palpitation. But even if you hear a murmur, don't like it's also possible in Kawasaki disease. Sorry, in MIS-C condition. Again, the respiratory, the renal, and the neurological manifestations are rare. So if you know those facts, guys, so then that is more than enough. So are you clear? Am I clear? Excellent. Good. So the thing is, guys, MIS-C, if you know, you can give a lecture, right? So the thing is, you will have a very clear idea. So the thing is, right? So you will learn everything so nicely. So after that, you will be just fine, right? And that's done. So the thing is, guys, differential diagnosis. So the Kawasaki disease. So that's the main DD, which like in most of, so the thing is, some children might have only again, the clinical picture differs, right? So some might have all the features of Kawasaki. Some might have only the conjunctivitis and the abdominal pain, right? So keep that in your mind. So here, guys, so if they again, most of the children will present with a mucocutaneous manifestation. That is the initial manifestation. So initially it will involve the skin and mucous membrane, then the GI tract, then the CVS, right? In majority. So that's why the most of the children at the initial presentation, so they will present with a high-grade fever and also the skin these mucocutaneous manifestations. So you can pick up easily, right? So Kawasaki disease is the one of the main differential diagnoses in MIS-C. Then of course, guys, so here leptospirosis. Again, I told you guys, some children can have fever, myalgia, and the conjunctivitis, maybe the right hypochondrial pain, the low platelets, right? Sometimes can involve the kidneys, right? So then, of course, sometimes you can get confused leptospirosis. So even our unit also, I was keep on telling, like we have also had an argument once, right? So the thing is, right? So the MIS-C child, right? Again, some people were telling it's leptospirosis, finally it was MIS-C, right? So thing is, guys, so sometimes people get confused because it shows a similar clinical pattern. Then the dengue. So dengue is very common. So I have seen so many people have overdiagnosed. So now the MIS-C MIS-C, right? So keep that in your mind. The dengue is far more common. So the thing is, guys, nowadays it's very common, dengue. So don't assume that. So sometimes children are presenting with a fever and a right hypochondrial pain, right, and a rash. Maybe the platelets are low, right? So the thing is, maybe the ultrasound scan also might show inflammation of the sometimes fluids following an inflammation of the GI tract. So thing is, guys, so don't get confused because the MIS-C again. You will the thing is, it's also mimicking condition, so you need to be able to differentiate. So then, of course, with the questions, you will be able to differentiate. You will understand properly how to differentiate. So the thing is, guys, then the toxic shock syndrome. So the toxic shock syndrome is something again which occurs following a streptococcus or staphylococcus. So streptococcus or staphylococcus, sometimes they will release lot of toxins. So these toxins can cause high-grade fever, rash, mainly the peeling of the erythematous rash and the peeling of the skin. So, hama galavi yanwa. And also, guys, so the thing is, and they can have shock, toxic shock. So, una rash, blood pressure is going low, fever, rash, and the low blood pressure. So, you might think, this is right. This and the other thing is, guys, most of these toxic shock syndrome can also involve whatever the organ commonly involve the GI tract. They can have diarrhea. So you can get confused. You might think this is MIS-C or right. So the thing is, or otherwise you might think toxic shock syndrome. So can be MIS-C. You should be able to differentiate with all the features. You need to get the support from all the features because there are so many mimicking conditions are there. That's why you need to know the clinical facts in and out regarding MIS-C. Everything, all the important clinical facts related to the MIS-C, you need to know in and out. Right? Otherwise, you will not be able to answer a single best question because there are so many mimicking differential diagnoses are there. So, thing is, guys. So sometimes the appendicitis. So then scarlet fever. Again, it's also like I discussed last week regarding scarlet fever. Again, they can have fever, the inflamed tonsils and pharynx, strawberry tongue, the rash, right, peeling of skin. Anything, all these features will be there. Again, scarlet fever also possible. Then the appendicitis, as I mentioned, fever, vomiting, maybe diarrhea, the high inflammatory markers, right iliac fossa pain. So thing is, guys, so those things, right, you might get confused. So then the sepsis, something like meningococcal, again, they can easily goes into septicemia, maybe, and a DIC. So thing is, meningococcus, they will have purpuric rash, right? It also causes vasculitis. So in addition to that, they will have a high fever, high inflammatory markers, right? So you can get confused and the blood pressure will start to drop following septic shock. So thing is, guys, so again, you can get confused. And sometimes the severe COVID-19. So the severe COVID-19, sometimes it can respiratory condition. Sometimes the severe COVID-19 per se, they can develop some rashes, right? Maybe urticaria rash. We have seen. So thing is, when the PCR and everything become positive, like if they develop some sort of rash, you will think, this is MIS-C. So the more important thing is in the COVID, the MIS-C, the lung signs are minimum, right? Majority will not have lung signs unless they develop these cardiac problems, right? So it's minimum comparatively, right? So thing is, keep that in your mind. So there are so many other DDs are there. These are the main differential diagnoses where you need to consider. So the key important thing is, guys, what? So the MIS-C is a diagnosis of exclusion. So if there is any evidence of other features, for example, if there is a positive blood culture, then can it be? It is highly unlikely to be MIS-C. Whatever the positive culture, right? So positive NS1 antigen, unlikely to be MIS-C. Should be more likely to be dengue. No, positive leptospirosis antibodies, right? Unlikely to be MIS-C, likely to be lepto, right? So it's a diagnosis of exclusion. So keep that in your mind. So that is very important. So I told you guys there were so many DDs are there, but the thing is, guys, so you should be able to differentiate the most important from the most common and the most mimicking condition. So which is MIS-C and the Kawasaki. So how are you going to differentiate MIS-C and the Kawasaki? So the one of the important point is, guys, what the age. So the age is what? MIS-C, of course, you will commonly notice in older children. So usually around adolescent age, right? Schooling age or the adolescent age, around 10 years. But the Kawasaki, you will notice in preschool age, preschool or the very young children. So between 6 months to 4 years. Then the abdominal symptoms. It's very common in MIS-C and it is very uncommon in Kawasaki. So I told you 90% of the children, or in Sri Lanka, 80% of the children had positive abdominal symptoms. So thing is, Kawasaki also possible, but it is rare. Then the cardiac involvement. cardiac involvement, guys. So the MIS-C, of course, it will mainly involve the myocardium and the inflammation of the vessels and the vasodilatation. So the commonly they will have a myocardial dysfunction and the heart failure, and also they can have hypertension and also the coronary artery inflammation, right? So that's why you will notice, right? So the inflammation of the heart, they will attack the myocardium mainly. So the myocardial involvement is so common, right? It can cause coronary aneurysms, of course, but commonly affects the myocardium. So the myocardial dysfunction is very common, and the hypertension is very common. So myocardial dysfunction and the hypertension is very common. But when it comes to the Kawasaki disease, again, it can cause anything, but commonly it will cause coronary artery aneurysm. So the coronary artery aneurysms are seen in 25% of the Kawasaki disease children. So it's very common, right? So you need to know. Then, guys, evidence of past COVID-19 infection. So the Kawasaki usually you will not notice, and the MIS-C, the rapid antigen may be negative most of the time. The PCR also, rapid antigen almost always negative. PCR also may be negative. But the thing is, guys, most of majority, the thing is antibody levels are COVID-19 antibodies are positive. But the thing is, guys, some children are there, so they might not have even the positive COVID-19 antibodies. So you need to go with an epidemiological link. So they might come tell, so I can remember one child was there. All the family members got positive for the COVID-19. So all have done the they have done only the rapid antigen test. So the rapid antigen test was positive in all the family members, mother, father, all the elder siblings, everyone. But there was a young sibling were there, youngest actually. So that child, of course, again for that child also they have done only the rapid antigen test at the initial stage with the contact history of COVID-19. So it was negative, and child had only mild nasal rhinorrhea only. So they haven't done the PCR. They haven't done. So the thing is, that child came with this MIS-C, right? So that time, of course, when that child came with the MIS-C, that time, of course, everything was negative, but all the rest of the features had. So we had to take that epidemiological link. So sometimes, guys, when they produce some abnormal antibodies, they will not exceed the T10 antibody, the maximum where they can detect from in the lab. So they will produce some little bit amount of antibodies, and that also can get reduced with time. So that's why there are some children are there who even their serology also can be negative. So you need to get the epidemiological link. We'll come to that. So then, guys, lymphocyte count. So thing is, guys, it's an inflammatory condition, sometimes even viral conditions also you might notice. So they will have lymphocyte count is very important. So the MIS-C, it is low. Lymphocytopenia is a very important feature. But the Kawasaki, it's not classic. The lymphocytes are less than 100. So you don't need no lymphocytopenia. So then, of course, the platelets. So tell me, can someone unmute and say, so Hussein Mustafa, so can you just tell, it's okay. What will you notice in the platelet count in Kawasaki?
Platelets should be normal.
Kawasaki?
In Kawasaki, I'm assuming it's going to be normal.
Kawasaki, the thing is, guys, the initial period, it can be normal. But the thing is, the classic thing is, guys, what? It's a significant inflammatory condition. So you will notice a thrombocytosis. Even huge amount of platelets will be there. So that's the platelet counts are usually it will be high. So that is a one important feature when you are looking at the full blood count to diagnose the Kawasaki. The platelet counts will be extremely high.
So what is the mechanism behind it? Since it's a
so there is a chronic inflammation will be there, right? So it is the Kawasaki, of course, there won't be any cytokine storm. So the thing is, there will be only antibody mediated. So these antibodies will reduce the inflammation. So the thing is, by that inflammation, there will be a reactive thrombocytosis. So it will stimulate the bone marrow and they will get reactive thrombocytosis. So they can have increased levels of platelets. But in MIS-C, what will you notice, Hussein? You might not aware, no?
Thrombocytopenia, maybe.
Yeah, exactly. So it's the way around. So you will notice thrombocytopenia because they will be a cytokine storm. So these cytokines will damage the vessels and the platelet will consume, as well as it can damage the cytokine itself can damage the platelets as well. So it can damage the platelets and also it can damage the blood vessels where all the platelets can get attached to the vessels. So the thing is, the number of platelets will get reduced. So the thrombocytopenia is more common in MIS-C and the Kawasaki thrombocytosis is more common. Then the inflammatory markers. So the inflammatory markers again very high in MIS-C. It will be again Kawasaki also it will be high, but it will be very high in MIS-C. So the CRP will be high in both conditions actually, and the ESR. But the thing is, these ferritin, triglycerol, and especially these D-dimer levels are very high in MIS-C. Those are the investigations. So in addition to that, the troponin I. So where do you to assess what do you do troponin I? So when there is any inflammation of the heart or ischemia or inflammation of the heart. So whether there is a damage to the heart. So it's a cardiac enzyme which releases following a cardiac muscle damage, right? So it's there inside the heart muscle. So it will release when there is a damage. So they won't be more than the ischemia. These toxins will and the antibodies will damage the myocardium. So they can have myocarditis. So there they can have high levels of troponin I. So some children you might notice high levels of troponin I. So that's why, guys, I told you initially they will have the mucocutaneous majority, then they will have abdominal, then they will have cardiac. So right, majority, right? So that's why if you pick up early and if you treat early, you can prevent developing significant complications and you can reduce the mortality. So the thing is, keep that in your mind. Good. So what are the key important points which I need to we discuss about the differential diagnosis? So guys, so here the important things are: do not miss MIS-C. So the thing is, guys, nowadays the people who didn't join for the lectures, as well as the people who are not well aware about these MIS-C and those who don't get update regarding the current conditions, so they can easily miss MIS-C, right? I told you, like even surgical units, they used to do appendicectomy very frequently. We have noticed 2-3 cases. There were 3 cases there, right? cases right? Appendicectomy karlama hospital ekata en. But the MIS-C. Right? So the other important thing is, guys, what? Don't miss the other common diseases. So there were so many children were there who actually managed their appendicitis, but the reality is, right? Sorry. So this is the opposite way, right? So thing is, guys, so here, give me a second. Right. So the guys. So thing is, guys. So we were discussing that. So the thing is, guys, do not miss the MIS-C. That is the first one. Then do not miss other common conditions. So what is it? What do you mean by that? So thing is, guys. So sometimes when you don't get so preoccupied. So some people are there nowadays. They are always thinking MIS-C, nothing else. So thing is, dengue is very much common. Right, the other conditions are even the lepto also very much common compared to MIS-C. So MIS-C is, you will notice, in 1 in 5,000 cases, right? So here the thing is, guys, so I have seen so many children who had managed as MIS-C, but the reality it was meningococcal sepsis. There was a case, right? There was a case with an COVID with an urticarial rash. While child had developed an allergic reaction, they have assumed that it was a MIS-C. There was a case like dengue, right? There were several cases. Reality was, the case was dengue, but they have assumed it was MIS-C. Then there were so many cases where they are right managed as so the thing is have managed as MIS-C, but the reality it was lepto. Right. Even the thing is Kawasaki also same. There were cases, and the thing is even there was some, the thing is the chloride inhalation poisoning also was there. But again, they thought like they have managed it as MIS-C. But the thing is chlorine. There was a chlorine inhaled induced ARDS was there. Adult respiratory distress syndrome. So the thing is, guys, don't overdiagnose. The thing is, guys, don't miss the other common diseases. So don't overdiagnose MIS-C. ඕනෑවට වැඩිය diagnose කරන්නත් එපා. So keep that in your mind. Even in your exams, don't assume that always this is MIS-C. So it can be Kawasaki, it can be scarlet fever, it can be dengue, it can be appendicitis, right? So keep that in your mind. So otherwise, after this lecture, you might consider all these things are MIS-C. So don't think like that. So go with all the features. Good. So the thing is, guys, so here. So the investigation. So the thing is, guys, what are the investigations you are going to arrange? So the thing is, guys, first of all, I told you, you need to make sure like whether the child had any evidence of child is having any evidence of COVID-19. So the first, of course, you will do a rapid antigen test. So, but almost always it will be negative. In Sri Lanka, of course, all the cases it was negative up to now, right? So the thing is, guys, the rapid antigen test is negative because it's a post-COVID condition. So it occurs following 2 weeks after the acute COVID. So the most of the time it will be negative. Then you can do the PCR. So the PCR, of course, sometimes. So if they develop this thing, so sometimes the PCR, like sometimes the PCR can be positive even for month or maybe for like really even can be 3 months. So usually can last even for 1 month positive PCR, right? So thing is, guys, so here of course again they can have positive PCR sometimes. So around 50% of the time, like the thing is, we noticed there was a positive PCR, 50% it was negative. So the key important thing is, guys, that when you are dealing with the PCR, now it can be infective. So thing is, Nishendri. So what else do you need to assess when you are checking at the PCR? PCR ka baladdi. Anything else do you want to assess in the PCR report? Or can anyone unmute and answer? Anyone? Anything else you want to assess? Yes, Susan, do you want to try?
The load.
Yeah, who's this? Can you tell your name?
Some Bhagya.
Yes, Bhagya. So the thing is, guys, both are correct. So the thing is, again, the viral load you need to assess. But how are you going to assess? With the CT value. So the thing is, guys, the CT value again important. So the thing is why it is important. So to decide where you are going to manage. So the thing is, guys, CT, what is CT values? CT value here. So CT value is the cycle threshold. Right, so the thing is cycle threshold of RT-PCR or the reverse transcriptase polymerase chain reaction. RT-PCR CT value is cycle threshold. So the thing is, guys, when you are assessing to detect the enough viruses, so they need to like the thing is rotate so many times, right? The virus they don't need to rotate that much. If the viral load is very low, so the machine should rotate so many times. So the cycle that is about cycle threshold. So the thing is, guys, if the CT value is high, so that means what they had to rotate so many times. That means the viral load is low. So CT value is again inversely proportional to the viral load or the infectivity. So CT value වැඩිනා viral load එක අඩුයි. CT value එක අඩුයි නම් viral load එක වැඩි or the infectivity is high. So the thing is, guys, so it depends on the machine to machine. So in some units, in LRH, of course, Laidridge Hospital, the 32 is the cutoff. Some units it's 30. Some units it's 35. It depends on the machine. So usually take it as 35. So if the CT value is 35, it is not infective. PCR positive kila natanna onne baya wenna onne. Ammo PCR positive kila because you can like it's not infective. If the CT value is less than 35, can be infective, but again, if it is like between 30 to 35, it is less infective, right? So it depends on, right? So basically, if it is less than 30, only like 20 or like something like less than 20, it is highly infective, right? So again, it depends on the value. So CT value is disproportionate to the viral load. So it is important to decide where you are going to manage. So whether you are going to isolate or whether you are going to just you can put the child into straight away to the high dependence unit, HDU, in the ward, or maybe straight away you can take to the normal ICU, right? So the PCR again important, that is same. But the thing is, guys, I told you PCR also will be negative more than 50% of the cases. Then of course, what do you need to get support? You need to get the support from the antibody levels. So with the serology. So the majority or the 60% of the children will have right positive antibody levels. But the problem is, guys, but some children, I told you, the thing is, some children might not have either positive RAT, positive PCR, or positive antibodies, because they might produce some antibodies which are non-neutralizing these abnormal antibodies. So those will not be that much high in number to detect, and it can go, the levels can go down with time. So thing is, guys, so that's why then you need to consider whether there is any epidemiological link. So that's important. So thing is, guys, investigations, what are you going to do to detect the evidence of COVID-19? So you do a rapid antigen test, PCR, and the antibodies, right? So that is important. Good. So thing is, guys, then of course, initial investigations, full blood count, what will you notice? So the hemoglobin can be slightly low, not important, don't highlight. WBC can be normal, low, or high. High is possible. Normal when not low when not high when not it's varies. So neutrophils will be more predominant. So 2 neutrophils will be more predominant. But the most important thing is what? They will have a lymphocytopenia and the low platelets. So low platelets and the lymphocytopenia. So the packed cells volumes, what will happen? So they can present with a shock. So the dengue, of course, when they present with a shock, what will you notice? So what will happen? You will notice the high levels of PCV, right? So the thing is, guys, in dengue, of course, shock happens due to the fluid leakage. So they will be a hemoconcentration. So they will have a high amount of PCV. But here, of course, they will be vasodilatation. So they will not have high amounts of packed cell volume. So even when they present with a shock, their PCV is not that high in majority. So the thing is, guys, CRP will be very high. So the ESR also will be very high. CRP will be more than hundreds, and the ESR will be more than 30, definitely. So it will be very high. So the thing is, guys, so what is the importance? So thing is, this is an important inflammatory marker, so which these investigations are freely available in labs. So in whatever the lab, so you can do it in even in periphery. So if it is high CRP and ESR, you can suggest. No. So but the thing is, ERP is very important in monitoring purpose. Why? Why, Hussein? I told there's CRP is more important in monitoring purpose rather than ESR. In this situation. So the ESR, again, it's a chronic inflammatory condition. So the thing is, here, of course, in the management, you are going to give IVIG. So when you give IVIG, so IVIG itself can increase the ESR. So after giving IVIG, you will not be able to monitor it properly. So you might think the ESR has been increased, but the reality is child is responding. So child's PV is going down, the CRP is going down, but the ESR can be high still, right? So the thing is, guys, so the monitoring purpose, the CRP is a more important one. Yes. Then, so the thing is, guys, so here important thing is, I told you it's a diagnosis of exclusion. So you need to send the investigation of to exclude the sepsis and the possible other differential diagnoses depending on the clinical findings. Depending on the clinical findings. Of course, you need to send the blood culture, urine culture, you need to check an X-ray and take a swabs from the relevant site. For example, if the child is having inflamed throat, so you might take a throat swab. For example, it can be scarlet fever. So you might take a throat swab, right? So those things are necessary, but because if it get positive, so it is not MIS-C or the highly unlikely to be MIS-C. Then, of course, depending on the other clinical findings and the DDs which you are thinking, so you need to send the other investigation, NS1 antigen. So the antigen is the important thing, right? Not the antibodies. So the antibody, dengue antibodies develop once they get settled. So in the acute stage, of course, even if we send the COVID antibodies, don't think that we need to send the dengue antibodies. So dengue antibodies are useless, right? Dengue antibodies get positive when they recovered from the dengue, right? After 6 days. So the dengue NS1 is the one which you, if necessary, which you need to send, or the right. So then the leptospirosis antibodies. So the ASOT, again, ASOT is for what? Versus streptococcal infection, no? So the conditions like scarlet fever, toxic shock syndrome, right? It will be helpful. So the thing is, guys, I told you there will be a cytokine storm, and there will be a significant amount of inflammation, and all the inflammatory markers will be so high. So thing is, guys, so all the inflammatory markers will be high, just like can you remember the condition which I discussed? There is something called macrophage activating syndrome. When I discussed JIA, or the Still's disease, or the systemic onset JIA, right? So in that condition also there was a cytokine storm, and they had high levels of all these inflammatory markers. So just like that, here also they will have high levels of inflammatory markers will be sky high. The most important one is the D-dimer levels. So the D-dimer levels, so it will tell you that there is a child is in a very thrombogenic state, and the thing is, they might very high levels may require higher doses of, or the treatment dose of enoxaparin, right? So the thing is, definitely it's a thrombogenic state. So the high levels are D-dimer is very useful to deciding whether you are giving high doses of enoxaparin or not. High doses mean the therapeutic dose. So it is very important, D-dimers. In addition to that, all the other inflammatory markers can be high: serum ferritin, LDH, right, triglycerol, procalcitonin. Even like the thing is, these are not cannot be done in normal laboratory setups, right? So the interleukin 6, right? So those things again will be high. Then of course, guys, so the thing is, you need to check the involvement of the other organs. So I told you it can involve the GI tract commonly. So then what do you need to check? So you need to check the liver function. So the AST/ALT will be high, the serum albumin will be low. So that's why most of the children, sometimes you might notice they might have periorbital swelling. I have the negative idimila. Maybe puffy gatiya, kammagen have cute baba tadisi gatiya tiyena commonly. So because of the low serum albumin, that's common. It can involve these blood animals, so it can involve the coagulation system. So they can have high levels of APT, PTINR. So thing is, guys, I told you GI tract, so they will come with an abdominal pain. So of course you will do an ultrasound scan. So ultrasound scan, sometimes you will notice colitis, so the inflammation of the colon. So you might notice little bit amount of free fluids over the abdomen. That's again, this is non-specific, right? So it is non-specific. You might notice some free fluids out the abdomen. You might notice a little bit enlargement of the lymph nodes or the mesenteric lymph nodes. You might notice inflammation of the bowel. You might notice hepatomegaly. You might notice peripolycystic kidney or the gallbladder edema, right? So those things are also possible. So the thing is, guys, sometimes it can mimic the dengue also, right? So keep that in your mind. So the thing is, guys, don't get confused. So those things are also possible. Then, guys, so I told you next organ is what? The heart. So when you notice what I told you, what will you classically notice? The myocarditis. No. So the myocarditis is the one which you will notice. So the thing is, guys, the ECG, the features of myocardial involvement might notice. So the ST depression, the T inversions, right? Those things you might notice. Maybe a bradycardia or tachycardia, or either bradycardia. Either is possible. Sinus tachycardia or bradycardia, anything is possible. Then what? Troponin I. So the troponin I, it will damage the cardiac muscles. So the troponin I levels will be high in most of the children. ලස්සනයි ළමයි මිස්සී patients ලාව දැක්කම පොත ඔය උගන්වපු දේවල් එහෙමම තියෙනවා ලෙඩාගේ. can apply things. Right? So then, of course, guys, the most important investigation is what? Most important investigation is what? The 2D echo, 2D echo, 2D echo. So the thing is, guys, keep that in your mind. 2D echo is extremely important. So you can assess how much it has been involved. So whether it has involved the endocardium or the valvular regurgitation is there. Whether there is an involvement of the pericardium, pericardial effusion is there. Whether there is an involvement of the coronary arteries. So whether there is any thrombus formation or aneurysm formation. So those things you can assist. And the most important thing is, guys, the involvement of the myocardium. So the myocarditis is the most important, not like the Kawasaki here. The myocarditis is the most important, the commonest manifestation. So the thing under cardiac problems. So the thing is, guys, so you need to assess the size of the heart and the function of the heart. So whether the left ventricular dysfunction is there and whether there is an ejection fraction is low. So your heart is not contracting properly and the ejection fraction is low. So then you need to, right, you can have an idea regarding myocardial involvement. So if it is severe, if there is a significant myocardial involvement, if there's a myocardial involvement, what do you need to do? So you need to manage in the ICU setup, right? So that's the important thing. So you can't just manage in the normal ward with a significant myocardial problem. So they might require inotropes with high doses with the insertion of the central line. So they need to monitor so closely. So then you need to admit to the ICU. So that's the important. So quickly, guys, so if I'm briefly summarizing what I discussed here regarding these investigations. So the investigations, the important thing is, first of all, identify whether there is any evidence of COVID-19 infection. But in the absence of laboratory investigations, you can't exclude. You need to get the epidemiological link. Then assess the full blood count. There, the most important thing is the lymphocytopenia and the low platelets. Then the inflammatory markers will be very high. And the thing is that will be noticed. Those are the basic investigations you can do. Basic initial. Then you need to exclude the other causes, the sepsis and the other disease. You need to send all the samples to exclude the sepsis and the other differential diagnosis where you with your clinical suspicion. Then you need to assess the other important inflammatory markers. So those inflammatory things are not available in the peripheral units. You can't do a D-dimer levels or the ferritin levels in the peripheries. No? You might have only the full blood counts, ERP and the cultures and that's all. So thing is, guys, then of course you go for the advanced one, where the thing is, here the thing is initially, unless you have a very high degree of suspicion. If all the features are there, you can straight away do all the investigations. But otherwise, the initial, if they present with a few features, you might start with the initial investigation. Then you go to the rest of the inflammatory markers because these investigations are very expensive. So the D-dimer levels, LDH levels, prolactin, procalcitonins, those things are very expensive. So the thing is, you don't straight away jump unless you are very pretty sure about the diagnosis. So then, of course, the thing is, if you have a doubt about the diagnosis, or if you want to do further confirm the condition, then you do the advanced investigation. So the inflammatory markers will be very high. The D-dimers are the most important one out of that. Then you can assess the involvement of the organs. So the thing is, guys, so I told you commonly involves the GI tract, so the liver functions and the APTTI, PTINR. And the thing is, guys, the ultrasound scan abdomen, where it will be non-specific, but it will be, you will notice several features, but don't get confused with the other DDs. So if you know what is happening exactly, then you don't get confused. Otherwise, if you are not aware, so I told you all to go through the questions. But if you know the things very correctly, then you will not get confused, right? So then, of course, the cardiac involvement, so they can have ECG changes, the positive tropi, and the echocardiogram also, you will notice significant. The respiratory, again, guys, the chest X-ray you can do, it will be non-specific. So the most of the time, guys, you will not notice anything, or you might notice evidence of pulmonary edema, right, because of the heart failure. But sometimes they can have pleural effusion following an inflammation of the pleura. That is possible. Inflammation of the pleura. Rarely only you will notice the features of COVID pneumonia, because they will come like few weeks after the acute COVID situation. So the COVID pneumonia, you will not find much features of COVID pneumonia. You will notice the features of pulmonary edema and maybe pleural effusion. Then the renal normal, but the thing is, guys, sometimes it can involve the kidneys as well. So the more importantly, guys, the serum electrolytes, they will have characteristics low sodium levels. The low sodium levels are very important. The majority will have less than 135 millimoles per liter. So that's why these children are sometimes easily become drowsy. So one of the reasons is they will have a low sodium levels. Good. So the thing is, guys, there were so many conditions there which mimics even the laboratories. These laboratory investigations also cannot confirm the single investigation cannot confirm the MIS-C. So you might get confused, right, or misdiagnosed. So thing is, guys, you need to diagnose MIS-C very accurately. So it's a diagnosis of exclusion. So if you go according to this order, so you will never miss the MIS-C. So the thing is, guys, so how are you going to diagnose? So there keep this in your mind. It's not straight away mentioned in the guideline, right, regarding this major mind. So for your, it will make everything easy. So keep this in your mind. There are major criteria are there. All the children will have all these features. So all these, if you are suspecting MIS-C, so these all 5 features should be there definitely. එකක්වත් නැති වෙන්න බෑ. එකක් හරි නැත්නම් highly unlikely to be missed. Because all the children will have all the features, all the main major criteria features or the main features. Then of course, minor is what? So if there is any involvement of 2 or more organs දෙකකට වැඩි involved වෙලා නම් and yes. So if there is all the major criteria 5 features of major criteria as well as involvement of 2 organs, then we can diagnose the MIS-C. Right? So keep that in your mind. So it's very easy. So what are the major criteria? So the thing is, guys, it should be childhood or in the young. It should be seen in a childhood or young adult. ඕගලන්ගේ වයසක 100ගේ මූණ රතු වුණා කියලා ඇඟ ඇහැ රතු වුණා කියලා 100 පප්පට එකපාර කියන්න එපා මිස්සී කියලා. මිස්සී කියලා. No, you will never see in 100 pappas. Right? You will only notice in pediatrics and the young adult age group. Right? Young adults. ඕගලන්ගේ ඇස් දෙක රතු වෙලා දිව රතු වුණොත් නෙක්ටර් එකක් බීලා වෙන්න ඇති. Are you a young adult? You guys are young? No. දැන් කීයද? නේද වයස? BCA කැලිත් නෑනේ ළමයි නේද? So the thing is, don't get scared, right? Even if you previously, if you got the COVID-19 also, if you develop some sort of hygiene or fever and a rash and everything, it should be something else, right? Not MIS-C. So you will notice only in children between 0 to 20, right? So the thing is, guys, so the fever should last more than 3 days. So these immune mediated ones, so definitely like it will be very high, right? So the thing is, I can remember one patient, like child was keep on getting like it's like this. The fever spikes are going 105, 103, 105, 103. Right? Even how much we give paracetamol, we used to give 4 hourly. Sometimes, right? No, it's not dropping so high. So the thing is, it was keep on going. But the thing is, some people will keep on telling, nah, this is exist. Right? So the thing is, right? They were, you know, in the here also the sad part is there are so many ego issues also there, no? Right? Ego issues are there. So the thing is, so they never accept. So what I want, the thing is, I always respect to these. I always listen to HO's opinions also, because they are the ones who are clerking and they are the ones who are always staying in the ward and dealing with the patients. So we are most of the time we also depend on their histories. No. So thing is, that's why we need to respect everyone. So thing is, when you all become the doctors or consultants, also don't be like mama tamai porotiyala oyan velem itan indepa. So be a normal person, right? පොළවේ පාය ගහලා ඉන්න කෙනෙක් වෙලා ඉන්න. So thing is, guys, so that ultimately the part of the prashna is so the children can suffer, right? So keep that in your mind. So thing is, guys, so thing is, fever will last, right? So more than 3 days. So thing is, guys, so then they will have high ESR and CRP. So that is a must. So both should be high. And no other cause of inflammation. So they can't have evidence of Kawasaki, they can't have Kawasaki, or they can't have either whatever the sepsis mediated inflammation, right? So they can't have any positive blood cultures or anything. So then, of course, it is highly unlikely. Then, of course, the fifth one is, guys, so past evidence of past COVID-19. So either positive PCR, rapid antigen test, PCR, serologic, or evidence of if there's any or epidemiological link of COVID-19. So මොකක් හරි එකක් තියෙනවා නම් then you can consider as evidence of past COVID-19. So මොනවාද පහ? So the age 0 to 20, the fever more than 3 days, high CRP, ESR, no other cause of inflammation, and evidence of past COVID-19. That's all. Very easy. Common sense. It's common sense. When COVID-19 tibba, ළමයින්ගේ තිබ්බේ CRP, ESR high එකක උනත් තිබ්බා. හරි සරලයි. So the thing is, guys, the minor criteria. So the involvement of 2 or more organs. So I told you commonly involves the mucocutaneous. ඒක විතරක් මදි. So involvement of the mucocutaneous or GI involvement or cardiac or hematological or renal or neural or right anything. So mucocutaneous is what? So as we discussed previously, rash, conjunctivitis, erythematous lips, or strawberry tongue, or inflammation of the hands and the feet. So if you notice anything about any of those, so you can consider involvement of the mucocutaneous. So the GI involvement is vomiting, diarrhea, abdominal pain, right? So the ileus or colitis, increased liver enzymes, right? Liver involvement. Then of course you can consider there is an GI involvement. So the cardiac means like if the cardiovascular means if there is an hypertension or shock, if there is any right evidence of heart failure, the increased levels of troponin I, the echocardiogram shows the involvement of myocarditis, myocardium, endocardium or pericardium or coronary arteries. So whatever the cardiac involvement we can consider, it is positive involvement of the cardiovascular system. So the hematological means if they have high levels of PTINR, APTT or altered fibrinogen levels and the high levels of D-dimer, again you can consider the hematological involvement. So then the respiratory, of course, then there is, and most of the time you will not notice if there is any evidence of pneumonia, pediatric respiratory distress syndrome, the pulmonary, right? So then you can consider. Then the renal, of course, if there is any acute kidney injury, features of acute kidney injury, and the neurological, if they develop a stroke, seizure, right? Meningoencephalitis like features, then you can consider. So the thing is, guys, commonly you will notice these 4 things. So the thing is, if there's a mucocutaneous, GI, cardiac, or hematological, right? More than two or more, right? 2 or more involvement of these organs, we consider it as positive minor criteria. So the all 5 major plus 2 or more organ involvements, we consider it as positive miss C. So you will never miss C. So the thing is, guys, the early diagnosis is very important, and the early treatment is reduce the complications and the mortality, because I told you you need to suppress the inflammation, right? So the thing is, guys, when you suppress the inflammation, then the complications will be minimum, right? So that's important. So you need to suppress the inflammation, so the heart will not get inflamed, the GI tract will not get inflamed, right? Even the brain and the other organs will not get inflamed, so they will not develop complications, and the mortality also will reduce. So the management may require multidiscipline. Sometimes it's not so easy to diagnose and manage. Nowadays, some we are well aware. But the thing is, guys, previously, of course, it required, right? So sometimes some children are not responding that much. There are rare cases are there, they don't respond that much so to the standard treatment. Then, of course, you need to get the support from the other people. So the thing is, sometimes you may, in addition to the pediatrician, you may need to get the support from the pediatric cardiologist, pediatric rheumatologist, right? So the pediatric hematologist, pediatric ICU intensive specialists, right? So you may need to get the help from them as well. So the thing is, guys, so here, so the management. So this is extremely important. So keep this in your mind. This is an emergency. This is an emergency. So thing is, guys, most of the most of the children, right, can present, right? There are significant number of children can present with the shock and the hypertension. So thing is, guys, that's why you need to manage the airway breathing circulation. So if they present with a shock, so when you are suspecting Kawasaki child with an so lethargic, irritability, ill looking, so you need to attach one pulse oximeter and the cardiac monitor, right? So the pulse oximeter, you can assess the saturation, the pulse rate, every respiratory rate, and the cardiac monitor, you can assess the ECG pattern if there is an arrhythmias or any other problems are there. So you need to assess the vital signs, the pulse, capillary filling time, right? And then the blood pressure, right? So those things you need to monitor. So the pulse, of course, it can be brady or tachy. The capillary filling time can be prolonged. But the important thing is sometimes you might not notice cold peripheries because sometimes the thing is due to this cytokine effect. So they can develop a warm shock, just like the sepsis. So when you touch the periphery, sometimes even with a prolonged capillary filling time, they can have warm peripheries. So the important thing is, guys, classically with the vasodilatation, you will notice low blood pressure or the hypertension or the low blood pressure is very classic. So the thing is, guys, this is a warm shock. So there is no vasoconstriction. There will be vasodilatation. So what kind of a shock you will notice? So in the here, dengue, what kind of a shock you will notice, Hussein? Can you tell? What kind of a shock? What will you notice classically?
You mean the periphery specifically, or
no? Blood regarding blood pressure. What kind blood pressure? What will you notice classically?
With a narrow pulse pressure.
Excellent, very good. Now, very good. Narrow pulse pressure. You will notice a narrow pulse pressure. But here, this is like a septic shocks. You will not notice a narrow pulse pressure. More than narrow pulse pressure, you will notice a normal or wide pulse pressure, right? Even with the low blood pressure and the wide pulse pressure is more common, right? So thing is that again helps you to differentiate from a dengue shock. Like shock in hospital, right? So it can be either a septic shock also, they can have wide pulse pressure, or here also they can have. Right. So thing is, guys, you need to assess the airway breathing circulation. You need to assess the monitor the vital signs, the pulse, capillary filling time, the cold peripheries, and the blood pressure, as well as the respiratory rate, the saturation, and assist with the cardiac monitor whether the rhythm is going properly. And you need to assess whether there is any evidence of heart failure, or the left ventricular dysfunction. So that is important. So when you are giving fluids, you need to be very cautious. Otherwise, you might overload the child and you might kill the child. So thing is, guys, the child can goes into shock due to 3 ways. One thing is, guys, what? So child had a diarrhea. The child can have diarrhea. So the diarrhea itself can cause dehydration. Then I told you they will be vasodilatation. So that's the main reason for the hypertension. So they can have vasodilatation and the shock. And also the cardiac dysfunction. So thing is, guys, for the vasodilatation and this thing, the dehydration, you need to give fluid boluses high amounts. But the thing is, you need to be very cautious if there's any associated left ventricular dysfunction. So you need to assess whether there is any bilateral basal crepitations are there, tender hepatomegaly is there, ankle lead, pedal edema, or the sacral edema is there. So then, of course, if there's any, you need to be very cautious when you are giving fluid boluses. So the thing is, guys, so when a child comes to you, you give a normal saline bolus. The guideline says 20 ml per kg bolus you need to give and you need to repeat it. But I say you need to be very cautious. Just don't give, guideline doesn't say to evaluate these signs. So here when you are dealing practically, be very cautious. So thing is, right? So when you are dealing, if the child is having heart failure features, don't straight away give an 20 ml. If they have bilateral crepitations, the tender hepatomegaly, the enlarged hepatomegaly with an pedal edema, then of course you give an 10 ml per kg bolus, right? Unless child is having a profound shock. Be cautious. Right? So in the LRH, of course, we and our unit in the also we can do. We can assist with the. You should have proper skills for that. We can assist the size of the IVC with the ultrasound scan. We can do a fast scan. IVC size we can decide whether the child requires more fluids or not. But the thing is, in the peripheries, you are unable to do that. Right? In the most of the units, you are unable to do that. So the thing is, guys, you may be cautious with the clinicals. You need to assess the clinical signs properly. Then you give the normal saline boluses. So if there is no evidence of cardiogenic shock, so you can give a 20 ml per kg bolus, or otherwise be cautious. Then of course the thing is, sometimes the problem is there will be a vasodilatation. So after giving 2 boluses also, sometimes they might not respond. Why? The thing is, there was a significant vasodilatation. So then of course, what do they require? So they might require inotropes. So there are so many options are the inotropes, adrenaline, noradrenaline, mineralon, and the dobutamine. So what you must have learned these little bit about these inotropes also, no, in your medicine. So Nadisha Dilrukshi, so can you tell me what just okay, if you don't know, this doesn't matter at all. What is the inotrope you are going to choose out from these four? The consultant might say something else. Yes, tell me at the beginning, initially.
So adrenaline.
Yes, very good. Is there any reason? The kana shot muling dalatin hindada. Kana shot good. Anyway, so that's also important when you're marking MCQs. So the thing is, guys, so the adrenaline, it will act on the alpha receptors as well as the beta 1 receptors. So these alpha receptors are in the peripheral vessels. So the beta ones are mainly located in the heart. So the noradrenaline, of course, more heart specific, right? So here the more than the cardiogenic shock, sometimes the hypertension contributes more. Sorry, vasodilatation contributes more. So thing is, guys, in addition to increasing the contractibility of the heart, you need to constrict the vessels as well. So thing is, guys, then adrenaline, since it has an alpha on as well as the beta 1 action, so it is a preferable drug as the initial therapy. So you can start with the adrenaline, depending on the other parameters. You can decide on what to choose, right? So that is there. So yes. So the thing is, guys, then again, the left ventricular dysfunction. So significant left ventricular dysfunction. Milrinone is a preferable drug, but it is not really available. Then you can go for something like an dobutamine. No, you must have learned in these things in your inotropes in your medicine, right? Yeah. Okay. So the thing is, guys, you should be well aware about inotropes, right? When you answer the medicine question. So good. Then, guys, so the thing is, you go to the specific treatment. Now you manage the shock, right? So you need to start the specific treatment as soon as you diagnose the case, right? Right? So as soon as you suspect, the thing is, sometimes you might not be able to wait till the culture reports comes. Cultures and okkoma report you always need to go with the clinical things, huh? So that's right. So the thing is, here you give the, otherwise child can die. So the thing is, guys, I told you there will be a significant inflammation caused with the cytokine storm and the abnormal antibodies. So it will inflame the heart, it will inflame the coronary arteries. So you need to suppress the inflammation so significantly. So the thing is, guys, I told you in Kawasaki, of course, it was mainly the antibody mediated part. So that's why you gave only the IVIG. So it was because the steroids were not that effective, like you usually give in the refractory cases only. So because it is an IVIG mediated, the antibody mediated, that's why you give IVIG. But here it's not like that. Here, in addition to the antibody response, there will be a cytokine storm also there. So if you know these mechanisms, so you will be able to work out. So that's why you give, in addition to IVIG, you need to give IV methylprednisolone. So IVIG and IV methylprednisolone both are necessary. So you need to act so fast. So that's why you give IV, as well as the thing is they will have a gut edema also with a low albumin. So the absorption will be minimal. So IV methylprednisolone and the IVIG. So IVIG and the IV methylprednisolone. So there are several categories. I'm going. I thought I have muted you all, so I'm going to mute you all again. So thing is, guys, if you have any questions, you can unmute and ask, of course, right? So thing is, guys, if you have questions, right? So thing is, guys, so you give IVIG and IV methylprednisolone, so it will suppress all the inflammation. So even the cytokine storm also will get suppressed. So it's like a miraculous drug. Once you give the IVIG, it's like a miraculous drug. They will respond so rapidly, right? Just giving a one dose, one cycle of IVIG is more than enough. Right? Over 24 hours or over 48 hours. So thing is, that's more than enough. Settle. You give it the IV methylprednisolone. So it's like a miraculous drug. මේ මහ ලොකු දෙයක් නෑ මේ දුක් විඳ උණ ගියාම 105ට 6ට දුක් විඳ සීත වෙවුල ඉන්න ළමයා just මන්ට ඩයග්නෝස් කරන්න නැත්නම් අනිත් organs උත් ඉවරයි. Right? Right? You should be well aware about these things. නැත්නම් ළමයි නිකරුණේ suffer කරනවා. They are suffering, right? So you need to identify early. You need to start treatment early as possible. Then, guys, what? So you give you give drugs to reduce the thrombosis. I told you this is a procoagulant state, or it has a high risk of developing venous thromboembolisms. So they can develop either DVT, either coronary artery aneurysm, DVT, pulmonary embolisms. Anything is possible. So here, of course, in Kawasaki, we gave only the aspirin. So the aspirin, of course, we used to give high doses of aspirin in Kawasaki. Why? So the thing is, guys, so here, the thing is, guys, they will have a thrombogenic state will be there, thrombogenic state. So the thing is, there is an immune mediator, no, it will damage inflammatory condition, it will damage the blood vessels. So all the vessels are vulnerable to get thrombus formation. So we need damage to the blood vessels. So thing is, guys, so of course they will have it's a thrombogenic state will be there in the Kawasaki also. On top of that, they will have thrombocytosis or the high levels of platelets. Then thrombogenic state platelet to paddy. Then of course, what you need to give high doses of aspirin. But here the thing is, guys, so here what will you notice in history what will you notice? So here it's a thrombogenic state will be there. But the problem thing is, guys, the platelet will be low. So thing is, guys, if you high dose means what? You are giving a very high dose. That is 100 milligram per kg. So C arterial aspirin petta only 75 milligram petta or 100 milligram. So here they are getting 100 milligram per kg. That's in the Kawasaki. So if you give that amount in a child who is having a low platelets, I think it will bleed the. So be careful when you are giving aspirin, you give here low dose of aspirin. So thing is there. But the low dose will reduce the inflammation more commonly, but it has a minimum effect of reducing the minimum effect of preventing the thrombus formation and the embolization formation. So the aspirin then what do you do? On top of aspirin, you add inexoparin. So you give the aspirin as well as the inexoparin to reduce the thrombosis, thromboembolism, right? So if you reduce the inflammation, the aspirin itself, it will reduce the inflammation of the vessels and the other organs. So it will relieve the symptoms also, right? But the thing is, it's not, the low dose is not sufficient enough. It's not enough to reduce the incidence of the thrombosis. So in top of low dose of aspirin, you add the enoxaparin. So the enoxaparin also, again, the levels are depends on the level of the D-dimer. You decide whether you are giving the therapeutic dose or the, you don't need to know that much therapeutic there. Because D-dimer එක ගොඩාක් වැඩි නම් you give the therapeutic dose. If it is low, you give a prophylactic dose. So the important thing is you give both these things in the MIS-C. So easy then? Easy. So thing is, guys, so next important thing is, guys, what? So thing is here, you need to reduce the sepsis. So thing is, guys, sometimes at the initial stage, the cultures are not available. So you can't exclude. Just in case, like you might think immunological antibiotic, then is it rational? Yes, it's rational. So thing is, guys, so thing is, can you wait till cultures just in case if a culture can become positive? So thing is, guys, you can't exclude the sepsis, definitely. So giving antibiotics will not cause much harm. Right, and in addition to that, guys, most of these children can be there in the ICU setup. A lot of infections are there. They don't get baths. Right? Right? So they can get a lot of cross infections. And the thing is, you are given high doses of methylprednisolone, steroids. So their immunity can get further suppressed. So then, of course, guys, as a secondary prevention of these infections, you need to give empirical broad spectrum antibiotic. So we hadisi wat lady infection ekan nan ekat hariyawa omat secondary ewala kandak dena. So you need to start early as possible. Again, within 1 hour you start. So thing is, guys, you need to give broad spectrum antibiotic. Usually you recommend, because these mimicking conditions are also commonly occurs following streptococcus and the staphylococcus. So scarlet fever, streptococcus. Toxic shock syndrome, streptococcus or the staphylococcus, right? So you need to, these lepto also, and these are, it also responds to the antibiotics. So thing is appendicitis, it will respond to the antibiotics. So you need to give a broad spectrum antibiotic also, which covers the, also antibiotic which covers the staphylococcus as well. Broad spectrum, you give IV cefotaxime, and to cover the staph, you add IV vancomycin. Adelaide. So it's very easy. So pediatrics is easy, right? Easy, right? Easy. MIS-C is easy, right? Good. So if you learn these things very nicely and rationally, you will be able to give a lecture even tomorrow. All right. The thing is, learn everything so rationally. So the thing is, guys, other treatment options. So there are so many options are there. Parliament ke kata karanne. So the thing is, the opposition leader tocilizumab. Have you heard? Can you remember? So tocilizumab, again currently we are not practicing in the pediatrics, right? So these drugs, and chimera and tocilizumab, we don't practice. So thing is, tocilizumab is an interleukin-6 inhibitor. So I told you there is a cytokine storm will be there. So it will suppress these interleukin-6. It will suppress. Then anakinra will suppress the interleukin-1. So you don't need to know. So those things are also very, again, toxic drugs. Right, so these are immune modulating toxic drugs. We don't practice in pediatrics. We have done few trials in refractory cases. So refractory cases, those who don't respond to the IVIG and the methylprednisolone therapy, sometimes we might consider after rheumatological opinions and everything. So you don't need to know anything regarding these tocilizumab and the etc. So thing is, guys, so finally. So thing is, guys, so here monitoring, again, important. You need to assess the clinically. So the clinically is the main important thing. So the thing is, these IVIG and the methylprednisolone are miraculous, like a miraculous drug for this MIS-C. So when you start it, they will respond so rapidly, drastically. They will have very good response. So the thing is, then they will gradually improve their heart functions and everything also. Right? So you need to assess the clinical improvement, right? So then, of course, you need to advise regarding lifestyle models. They might require these compression stocking, right? They might require bed rest for some like around 2 weeks if they have developed cardiac disease. So clinically, you need to assess properly, and you need to assess the clinical improvement. Then the thing is, guys, you need to assess the reduction of the inflammatory markers. So when they are responding, in addition to in addition to the clinical improvement, there will be a reduction in the inflammatory markers also, mainly the CRP and the serum ferritin. Right? See, again, the CRP is the most important one. So to keep this in your mind, ESR we don't use to assess the improvement when you are monitoring, because once we start the IVIG, so we might get a false interpretation. So again, you need to do a 2D echoes, right? So in the absence of whatever the cardiac involvement, still you need to do a frequent 2D echoes. So in the absence of cardiac involvement also, you arrange a 2D echo in at the beginning, 2 weeks, and the 6 weeks, just like in Kawasaki. So thing is, guys, so keep that in your mind. So if I quickly summarize about the treatment, so most of them can present with a shock. Make sure you identify the shock, but the thing is, assess at the same time whether the child is having evidence of heart failure. So the thing is, you need to manage the shock with a normal saline boluses. Be cautious when you are giving, when the child is having heart failure. Then the thing is, guys, depending on the features of the heart failure or the way the child is have a poor response to normal saline boluses, consider about inotropes. Then, guys, you need to give the specific treatment to reduce the inflammation. IVIG and the metaprednisolone, which is the miraculous drug, it will reduce the inflammation of everything. Then you can reduce the thrombosis. You give the low dose of aspirin, and on top of that, you add the enoxaparin, right? You reduce the incidence of thrombosis. So you need to reduce the sepsis. So they can have secondary infections as well as you can't wait till the cultures to come. So you need to start empirical antibiotics, broad spectrum antibiotics as soon as possible. So the thing is, you need to give IV cefotaxime and the vancomycin. So then, of course, you need to monitor the child. So the important thing is clinical improvement of the CRP changes. So in addition to that, you need to do frequent echoes to assess whether the child is developing late complications. So the thing is, guys, we discuss about so many things. So we discuss about the what is basic things about these basic things about the MIS-C, the epidemiology and the risk factors, the pathophysiology and the clinical features, and the differential diagnosis and how to differentiate those things. Then the investigations, the diagnosis of the MIS-C, and finally the management of the MIS-C. So finally, the key take-home message is what? So do not miss MIS-C, and do not miss the other common diseases, and do not over-diagnose. So keep those things in your mind. So if you know those things, you will be able to answer the questions very correctly. So can you see the last picture? So I have seen similar cases, right? Right? So they will be like vampires, right? So the thing is, keep that, the conjunctivitis is a very important clinical feature. So the thing is, guys, so we have, the thing is, even you have learned this lecture, I told you it's a very tricky lecture because there are so many mimicking conditions out there. So whether you have learned the things or not properly, so you need to assess that with questions, right? So the thing is, guys, so we will quickly move to the questions, right? Good. So the thing is, guys, so here, take the questions. So I think I gave it today, I gave it to you today morning. So we'll move to the questions. So here. Right. So the thing is, guys, question number 1. So the 8-year-old boy presented with fever and sore throat for 1 day duration. Next day, child become flush and generalized rash all over the body, except over the face. On examination, child was 5 here, 102 Fahrenheit, The enlarged purulent tonsils and strawberry tongue and bilateral cervical lymph nodes were noted. Rash was papular in papular, and it was in the erythematous background. No conjunctivitis noted. The rest of the systemic examination was normal. The full blood count, hemoglobin 11.5, WBC 20,000, the neutrophils 80%, the lymphocytes 18, the platelets 380, the CRP 90, the ESR 28, and the UFR normal. The ASOT 400, the chest X-ray normal, the blood, urine, and the throat swab cultures were negative. Were negative were not available. Were not cultures were not available, right? Right. What is the hambelane, right? Not available, not negative. It's not available. So what is the most likely diagnosis? So thing is, guys, so they have mentioned the Kawasaki disease, rubella syndrome, rubella, the scarlet fever, MIS-C, and the rheumatic fever. So thing is, guys, so can you send me your answers quickly? Yeah, I think very few have made the mistake. So the thing is, guys, so majority have given the correct answer. But because I think I explained it so nicely and in detail, right, during the last week, almost similar question. So I think most of you all are able to, right, okay, Sudhira, right, so thing is, all of you all will be able to get the answer correctly. So thing is, guys, so Kawasaki disease, so thing is, guys, so I told you Kawasaki disease, some few students have sent it as Kawasaki. So thing is, guys, Kawasaki disease commonly you will notice in preschool age, right? And the thing is, guys, the majority will have an conjunctivitis, right? So the here the rash also, that's not the typical of the Kawasaki disease as well. And the ASOT will not be so high in Kawasaki disease. So the rubella, of course, again, they will have lymph nodes, fever, and a maculopapular rash usually, maybe with the joint pain, but the other things are not suggestive. The rheumatic fever, guys, again, the rheumatic fever, they will have a high level, some students, few students have sent. So they will have high levels of ASOT. Just note high ASOT value condition. No. The ASO, high levels of ASOT and the CRP and the ESR are the only things to suggest rheumatic fever, but there are no any other things to suggest. There are no any other major criteria. No cardiac involvement, no joint involvement, nothing is there. So then, of course, guys, rheumatic fever totally up. So the MIS-C, again, it can see in around 8 years. Again, yes, that's possible. Fever and the sore throat, again, that's possible. So the rash is not the typical, but this kind of rash is possible. And the thing is, enlarged purulent tonsils and the strawberry tongue and the cervical tender lymph nodes are there. So the thing is, guys, immunological conditions, usually the lymph nodes are non-tender, right? So that is there, and this is bilateral also. And also, guys, there was no conjunctivitis also, right? Fine. So the MIS-C, of course, most of the time, they will develop conjunctivitis. And the rest of the examinations were normal. So there is no criteria will not fulfill. So they haven't mentioned anything regarding the past history of COVID-19 or whether there is any serological evidence. And the thing is, guys, the thing is ASOT is obviously high. So there is an obvious evidence of another infection. And the other thing is, guys, right? So there is no full blood count also. There is no thrombocytopenia, right? And also the thing is, guys, the conjunctivitis is also not there, and no more than 2 organ involvement. So the thing is, guys, so I told you, MIS-C, there should be more than 2 involvement, organs should be get involved. So here only the mucocutaneous manifestations, no cardiac or the serious involvement. But the scarlet fever is something, it's a condition where again you will notice in a children. I explained last time very nicely that in a school in children, toxic, it's a toxic mediated one, where the streptococcal, it's a streptococcal infection, streptococcal pyogens for the group beta hemolytic streptococcus, where they will release lot of toxins, where it will involve the mucocutaneous, they will develop mucocutaneous manifestations common, and also can have sepsis. So the mucocutaneous manifestations are the fever, the involvement of the enlarged tonsils, strawberry tongue, and the erythematous lips. Then the rash, mainly the sandpaper appearance. Can you all remember? I told you last time, no? Sandpaper appearance. You will notice small papules over the red background. So that is very important. So the thing is, guys, the cervical lymph nodes also will be there, and sometimes they can have peeling of skin. But here again, the scarlet fever, they will not have conjunctivitis. So the schooling age, no conjunctivitis are the main features to exclude the Kawasaki. So the thing, and these Missy also. So the thing is, guys, Kawasaki. So the thing is, this is all the features are more suggestive of scarlet fever. So thing is, guys, when you get an SBA, so make sure all the features should match to that particular answer. Don't go with one symptom or sign. Make a matching no. So we'll move to the next question. So 2-year-old boy from dengue epidemic area presented with fever for 5 days and abdominal pain and vomiting for 3 days. On examination, child was febrile, the bilateral conjunctivitis, and the maculopapular rash with tender abdomen with 1 centimeter hepatomegaly noted. The pulse rate was 120. The capillary refilling time was 3. The warm peripheries. The blood pressure 70/30. The mother had experienced COVID-19 1 month back. An elder brother who is 15 years currently treating for dengue fever in a medical ward. Very practical case scenario. So thing is, guys, ඔය වගේ ළමයි ඕන තරම් අපිට practically ඉස්පිරිතාලේ හම්බෙනවා. ඒ ළමයාගේ case එක SB එකට දාන්න. Right? So thing is, guys, full blood count, hemoglobin 14, the WBC 6,000, the neutrophil 78 with a lymphocyte 16, the platelet 115, the Paxil volume 42, the CRP is 130, and the renal functions and the UFR normal, rapid and the PCR both negative. The ultrasound scan edematous gallbladder with mild fluids over the abdomen and pleura. So what is the most likely diagnosis? The leptospirosis, dengue hemorrhagic fever, the MIS-C, polycystitis, and the glandular fever. So send me answers. Very good. I think most of you all have got the concepts very correctly. So the thing is, guys, but there were very few students have made some mistakes. So the thing is, guys, so here the important thing is, guys, what? So the thing is, of course, glandular fever is IMN. So even they have a low platelets and sometimes the hepatomegaly is possible. But the other features are not so suggestive of glandular fever. So the thing is, cholecystitis, again, these conjunctivitis and these very low blood pressure and the other things are not so suggestive. Again, the leptospirosis, they should have very high levels of WBC. The WBC should be high, right? And there is no evidence of muddy contact, right? So the other investigations are also not so suggestive except the low platelets and the tender hepatomegaly. No. So the thing is, guys, so the main two DDs and most of y'all have answered either B or C. So the thing is, guys, so here the child is from the dengue epidemic area and the child is again my elder brother also treating for dengue in the medical ward. So the pediatric cutoff is the 14 years. අවුරුදු 14ට වැඩි අයව ඇඩ්මිට් කරන්න medical ward එකේ, right? 14 අඩු අය තමයි pediatric ward එකේ. So the thing is, guys, this child is having the low platelets. Here the ultrasound scan shows gallbladder edema. Gallbladder edema එකක් එක්ක තියෙනවා with a mild fluids over the abdomen and the pleura. එහෙමනම් මොකද්ද මේ ලෙඩේ? This is dengue hemorrhagic fever with, or the dengue with leaking. Dengue with leaking. Right? So to keep that in your mind. So the thing is, guys, I told you the misty can cause anything, right? Can involve any organ, so mainly the abdomen. So the thing is, guys, so again, why it's not dengue hemorrhagic fever or the dengue with leaking? Why it is not? So the thing is, guys, so even they have a peripolycystic fluid or the abdomen, edematous gallbladder with a free fluid over the abdomen. So usually leaking occurs in the at platelet count part level. Usually it should be less than 100, less than 100. Right, so leaking usually does not develop above 100 of above 100 platelets. So here the platelet count is 150. Then, guys, the other thing is, guys, right? So the Paxil volume also should be high. So the Paxil volume is 42 is the cutoff. You know, in the guideline also say, but the thing is, guideline is sometimes it's a very stupid thing. Sometimes they mention in the 42 as the cutoff. So the thing is, guys, it always depends on the hemoglobin level. So you need to consider the normal Paxil volume by multiplying the hemoglobin into 3. I have told in the dengue lectures also. So if the hemoglobin is fell, so then the 36 is the normal amount. Then of course 20% price එකක් කියන්නේ 42 තමයි එන්නේ 36 ළමයික. Then again correct. But the thing is, guys, in a child with an hemoglobin 50, then of course what? So his normal level will be 45. You know, 48, 40. So you need to consider. So their levels will be normal. So here the hemoglobin value is 14. 14 is what? So anyway, their normal Paxil volume is the 42. So this is a normal PCV, right? Now a child's blood pressure is low. You might think our child is in a shock stage now. Yes, blood pressure is low, but in the dengue fever, of course, what kind of a shock you will notice? The narrow pulse pressure. So narrow pulse pressure is, guys, what? So the blood pressure is low and it is less than 20. So here what? It is more than, this is 45, 60, 70, 45, more than 40 pulse pressure. So it's a wide pulse pressure. So the thing is, guys, so here the around 9 is that the highest incidence. Again, there is a mother also has experienced COVID-19. Child had a fever for 3 days, and the conjunctivitis is there. And the maculopapular rash, tender abdomen with 1 centimeter hepatomegaly, right? So the lymphocytopenia, thrombocytopenia, right? Very high levels of CRP. Dengue, will they develop an high CRPs? No. Right? So the thing is, guys, so they can have an edematous gallbladder, as I mentioned. So they can have colitis and the inflammation of the gallbladder and the liver also possible. So if you have taken those facts very correctly, so I think majority have. So the thing is, the answer is mistake. So next one. So again, another common case scenario: 8-year-old child admitted to the surgical ward with fever, diarrhea, and the right iliac fossa pain for 2 days duration. Right? So the ultrasound scan suggested enlarged mesenteric lymph nodes. Clinically, appendicitis suspected. So it can be mesenteric adenitis clinically they have suspected mesenteric appendicitis. This is a practical case scenario, right? Which happened suspected and child underwent appendicectomy on day 3 of illness. No inflamed appendix were noted, and child presented persistent to have high-grade fever while on 2 broad-spectrum antibiotics for 3 days. So the thing is, pediatric referral made. On examination, child was febrile, drowsy. Drowsy, I told you it's common because they will have an associated hyponatremia, ill looking. Also noted to have bilateral conjunctivitis and the edema of the eyelid. Low albumin can cause edema of the eyelids. Inflamed lips and purpuric rash. Hepatomegaly 3 centimeters, no splenomegaly, the pulse pressure 60, warm peripheries, blood pressure 70/30, and the capillary refilling time 3 seconds. So The hemoglobin 10, WBC 12,000, neutrophil predominance, and the lymphocytes 15%, platelet 80. The APTT, PTIN are high, the D-dimer levels are high, the RAT and the PCR is negative. What is the positive? There is a positive contact history of muddy water as well as COVID-19. So what is the most likely diagnosis? So send me answers. Meningococcal sepsis, disseminated intravascular coagulation, leptospirosis, dengue, fever, and MIS-C. So the thing is, guys, most of the time, if you didn't learn these things properly, you might consider meningococcal sepsis sometimes, because with the purpuric rash, fever, right, and the shock, you will consider. And the disseminated intravascular coagulation also you might consider. With these kind of a thing, the poor response, the low blood pressure, and the high levels of APTT, PTINR, and the D-dimer levels, you might consider. But the thing is, guys, now you know everything, the facts very rationally. So you will not make any mistakes. So the thing is, guys, so here, the thing is, even if it is meningococcal, they will rapidly respond to antibiotics, because meningococcal is which is a main infection, which causes very high mortality. But I was keep on telling you all, it is very organism which is very easy to kill, right? Saddedana අස්ථාවරයි කියලා තියෙනවනේ. නටන අය අස්ථාවරයි, දඟලන අය අස්ථාවරයි, තැම්පත් වෙලා ඉන්න අය ඊට වැඩි ස්ථාවරයි. එහෙම එකක් තියෙනවනේ, ඒ වගේ තමයි. එහෙම වෙයි කියලා මේ තැම්පත් වෙන්න යන්න එපා. So you right? ඕනෑවට වැඩි නටනවා නම් මේ. So the meningococcal is something like that. ඕනෑවට වැඩි නටනවා, so the අස්ථාවරයි, so the thing is then easy to kill. So that's why they will respond so rapidly. So the thing is, leptospirosis, again, they can have a conjunctivitis, hepatomegaly, everything. But these, they have positive contact muddy water also. But the thing is, rest of the features, the erythematous lids, these inflamed lids, right? So, and right, so the poor response to the antibiotics, right? So those things are lymphopenia, right? And the high levels of high levels of D-dimers, that is very high, 1,000 to 10,200. 10,200, very high. So thing is, guys, so those things are more suggestive of MIS-C. Next one, 10-year-old child who had a positive for SARS-CoV-2 2 weeks back, presented to the ETU following fever, sore throat, rash for 3 days duration. On examination, child was lethargic, pyrexial, inflamed oral cavity, and maculopapular rash. Mild generalized abdominal tenderness was present. The auscultation of pansystolic murmur, best heard over apex. Lungs were clear. No hepatomegaly. The pulse rate 70, and the blood pressure 75/35, and the capillary refilling time 4, and the warm peripheries, and the investigation results done outside previously are again award blood check කරලා තියෙනවා කලින් දවස්වල. ඒකේ results. So the full blood count, WBC 14,000, neutrophil 80%, with a lymphocyte 18, platelet 98, hemoglobin 9.8, packed cell volume 40, and the CRP 190, ESR 60, CBS 280, and the UFR protein 2+. What is the most appropriate immediate step in the management? So the IV fluids, IV furosemide, IV normal saline bolus, IV empirical antibiotics, and the blood culture. So send me answers. ඒක ටිකක් slow ඒවනේ. අරවට ටාර් ගාලා ඉවුවා. Yes. ඒක නනේ කට්ටි very good. Piranvi, I didn't expect the answer like that kind of answer from you. Very good, guys. Very good. So thing is, guys, so here, so the important thing is, guys, so a 10-year-old child with them. So this is about the typical MIS-C picture, no? So previously child had a MIS-C, and these and all the features are there. But the thing is, guys, in addition to the classic features, you have noticed child is lethargic. ළමයා මලානික වෙලා ඉන්නේ. Right? Their child was lethargic. And the thing is, guys, in addition to that, clinically, so the thing is, yeah, you read, no? So here, some students have sent IV insulin, very quick. I told you last week also. So do you get panic when you see an 280 milligram per deciliter? So what is the cutoff? Random 200. So even then ඔයාගේ check කරොත් දැන් ඔය හොරෙන් කන ළමයි ඉන්න ඔය වෙලේ ඔය තේ බොන ඔය ඉන්න ඔතන ඉන්නවා කීපදෙනෙක්. So මොකක්ද වෙන්නේ? What will you notice? So sometimes it can be more than 200 also possible. Right? Kanna, right? So you are feel free to eat, right? So you eat. So these guys, here, 280. Why the sugar levels are high in this child? Hussein, can you tell, Mustafa?
Because of the stress response.
Excellent. Because of the stress response. So when they have some, like when they expose to some sort of stress, again their cortisol can be high. So due to stress response, it can be. So don't get so panic out about just look at seeing abnormal, just high CBS report. So don't start insulin on those children, right? So you can worse the condition. So thing is, guys. So then. So here, so thing is, guys, of course, you need to start IV antibiotics, and you may need to take blood culture. Some students send the answer D and E also. But the thing is, guys, so this is a post-COVID. Even you need to, of course, you need to start within 1 hour's time. You may need to exclude the other conditions and start. But the thing is, the picture is more towards, it's a typical missing. Like, because there is an obvious COVID history is there, right? And the cardiac involvement and the mucocutaneous involvement and the counts also, everything suggests. So then, of course, when it is an obvious typical missy, so the thing is you need to take a blood culture, but that's not the most important thing. So the thing is, even before that, you need to make sure whether you need to check whether the child is stable or not. So the thing is, guys, so here, so some students have mentioned IV furosemide. So the IV furosemide you need to consider when child is having a cardiogenic shock. So you need to prop up the child, give the oxygen and the cardiogenic shock. So here the thing is, the auscultation, there was a pan-systolic murmur. Of course, now there is an MR is there. Also there. But the thing is, guys, the lungs were clear. So if there is any heart failure, what will you notice? You will notice a bilateral basal crepitations. And they will have a tender pulsatile hepatomegaly. It's an edema, no? Significant edema. So these lungs are clear and no hepatomegaly. So clinically, there is nothing to suggest heart failure. So the IV furosemide is not necessary at this moment. So here the problem is, guys, what the child is having a bradycardia is going. But the thing is, blood pressure is low, 75 by 35. 10-year-old child should have 90 by 60, right? So the 75 by 35, that's a low, and the capillary refilling time prolonged. So the thing is, child is in a shock stage. So then, of course, guys, what you need to give IV normal saline bolus. Usually, in this child, you can give 20 ml per kg bolus. Are you clear? Good. So is it easy? Yes. Now the thing is, guys, it might not get easy. Like if you straight then exam ekedi hambuna, telima mulimma hambuna na, so you will make those mistakes. Now you will not make any mistakes. Now you know. Again, I put a scarlet fever also because otherwise you will get preoccupied. Natta හැම එකම උත්තරේ මිස්සි දැම්මොත් exam එකේ හැන්දලෙන් මිස්සි හිතන්න. No. Now you know there are other conditions also. There are mimicking conditions. So don't jump that all the conditions are missy. So make sure whether it is missy or something else, right? Now you have enough knowledge to differentiate those conditions. So missy related questions, MCQs. So true or false regarding multi-inflammatory syndromes in children? Seen only in pediatric age group. False. So you will notice in young adults also, pediatric age group young adults right? So up to 21 years you will notice, so that is false. So fever is almost seen in almost all the children. Yes, in Sri Lankan setup it's 100%. So in the guideline also, that's why you have mentioned fever is seen all the children. The positive PCR is seen in majority. No. PCR will be negative in majority. The serology will be positive in majority. They can present with shock stage. Yes, they will present with shock stage, right? So that's why it's important to know about these things. Will respond to IV and IG. It's like a miraculous drug. Yes, they will well respond to IV and IG. So which of the following correct regarding Miss C? So the commonly seen in preschool children. No, you will notice Kawasaki in preschool children. This is noticed in schooling or the adolescent age or the around 10 years. Thrombocytosis. No, not thrombocytosis, guys. You will notice thrombocytopenia. Thrombocytosis you will notice in Kawasaki. Absence of positive PCR and the serology exclude the diagnosis. I told you guys, most of them will have negative PCR. The serology also, it will be negative in some children. So I told you since they are producing these abnormal antibodies, which might not be able, the amount will be low, so which you might not be able to detect. So the thing. So these days I forgot to mention, guys. So the thing is, in future, of course, it will be very difficult to diagnose the condition. Why? So the thing is, most of the children will get positive following COVID, and the majority of the children will have positive serology. So the thing is, child can present with dengue with positive serology. The child can present with serology of COVID. Child can present with positive lepto with a positive serology of COVID. Septic shock, positive serology of COVID-19. So in future, of course, the diagnosis will be very difficult. And the thing is, this is something updating topic, right? Even the COVID-19. So the thing is, guys, if there's any update, I will let you all know. So keep in touch. So I will let you all know. So the thing is, guys, the other thing is, guys, now we are going to start the immunization. So when we start the immunization below, right, in children, so again, the problem is they will have a positive serology. Then, of course, we will find difficulty in diagnosing the conditions. So the thing is, guys, so here the epidemiological link is very important. So the coffee is a prominent feature. No, it's not false. So the coffee you will not notice. The can mimic appendicitis, obviously true. So which regarding mystery, high number of cases can be seen after an acute COVID pandemic wave. Okay, wave එක කාවට පස්සේ තමයි වෙන්නේ. So that is there, right? So that's why nowadays you are seeing more and more after the first wave and second wave. You didn't notice because they were very minimum number of child pediatric cases. Now you will see because there are like so many cases after a pandemic. You will notice. Children are obese, likely to have complications? Of course, yes. Obesity is a main risk factor. Have atypical Kawasaki features? True. It is diagnosis of exclusion. Yes, you need to exclude the other conditions. Response to treatment is assessed with ESR and CRP. Response to treatment is not assessed with ESR and CRP. It is assessed with the CRP. Plus or minus serum ferritin. Why? Because the thing is, once you start the treatment, IVIG, so it will alter everything. Which of the following suggests Miss C? Can Kawasaki disease? Preschool age. So it is more towards Kawasaki, not the Miss C, so that is false. Fever more than 3 days. So the thing is, guys, fever more than 3 days in the criteria, even we mentioned, even Kawasaki, what is the criteria? Fever should last more than 5 days. So both will have more than 3 days. So even if a child comes to you, fever more than 3 days, will it suggest more towards Miss C? No, we can't differentiate. So that is false. You will not be able to differentiate the Kawasaki and the Miss C by looking at the duration of the fever. Recent past contact history of COVID-19, of course true. Abdominal pain, of course true. Thrombocytosis, what do you think, guys? True or false? Yes, guys, very good. That is obviously false. Thrombocytopenia. So the thing is, guys, how do you feel about Missy? Then, ඔක්කොම ඉවරයි. ආයෙ ගෙදරදී පාඩම් කරන්න ඕනද Missy? No, I recalled several times. Again, I went back and I recall. So you don't need to again study again and again, like time to time. Just go through just have a picture memory. That's more than enough. So thing is, guys, you will be just be like, thing is, now hope you all, if you listen to my lecture, you of course definitely you must have developed a very clear idea. You will be able to answer whatever thing. It's not an easy thing lecture, but I have made everything so easy, right? So you will not. The thing is, guys. So the thing is, now it is so easy for you all. So you will be able to answer whatever the question. So the one of you notice is there again. The Dr. Larendra again asked me to mention it. And the thing is, he's one of my very good friends. So the thing is, he also doing a one free class. Again, Sudhir will send you a link so you can, if you are interested in joining. So he's a very nice teacher. He will teach everything so nicely. So you can learn the medicine also very nicely. Right? So you can fill that link. So the thing is, guys, so the COVID in future also, the thing is, this is a new topic. So you will not find any questions. You will not find the questions related to the MISSI in your past papers, right? So, but this time you might see. So, thing is, have an idea. So, if you know this amount, that is more than enough to answer all the questions, right? So, thing is, guys, so it's really pleasure to have, right? It's nice to have the lecture with you all. So, it's right. You also, most of y'all, I noticed you very actively participated. So, thing is, very happy. So thing is, guys, your positive feedbacks and things are very important. So if you can send me, like, I'm appreciating that students are sending me through this WhatsApp message, through these Zoom chat. Also, you can send me through these WhatsApp. So thing is, and if you find any doubt, so that will motivate us, right? So that will encourage us. So your comments are the most important thing. That's why, like, the thing is, the only I'm doing these 2 classes are free this month. So because we have more time, I'm doing for everyone. So the thing is, your positive feedback is the most important thing, right? So the thing is, guys, I know you are really happy about these classes. That's why you are joining, and the feedback is very important. So the thing is, guys, learn everything nicely. So the thing is, make everything so, like, the thing is, don't make things complex. So learn the other lessons also, the topics also very rationally and in a methodical manner. So you will never forget, and you don't need to study that much also when you study the things very rationally and in a correct. So the thing is, guys, so then we'll stop for today. So then have a nice day.
Thank you, sir.
The students who have questions, they can stay and ask. Huh?
Sir?
Yes.
Sir, in addition to MIS-C, can COVID-19 also cause Kawasaki disease?
No, the COVID-19 post-COVID is the Kawasaki disease. So the virus again can affect. Virus per se can affect the virus per se can involve the mucocutaneous involvement and the cardiac, in sometimes the thrombosis, right? So the COVID-19 itself, but the thing is, it's very minimal. So you will not notice this typical picture or the classic picture just following COVID-19. But virus also per se can cause rarely. It's there. Any other questions, guys? You can unmute and ask. No questions? Do you have any questions? Please unmute and ask if you have any questions. Right. Then I see you don't have questions, huh? Right. So I guess everything is so clear then. Right. Then, guys, we'll stop for today. So then, have a nice day.